Okay, my colleagues. We can't hear you. Hi.
When we talk about empiric therapy, it's typically determined by two factors. One is your scientific guess, and second, by the status of the patient. Your scientific guess is determined by many factors. One is the clinical, the history, the sum of the labs, whichever you can get, to determine the anatomical site of the infection, saying pneumonia.
Usually heard it from our dear colleagues, don't change a winning team. Discontinue vancomycin. Okay. Okay, discontinue vancomycin. Continue the same antibiotics. That's change. Change piperacillin tazobactam to meropenem since the patient still spikes, she has still spikes of fever. Discontinue vancomycin and piperacillin tazobactam and start ceftaroline. There is a missing, what happened to the, one of them is missing. Okay. راح واحد. فين راح? So let me see, what do you like to do? Discontinue vancomycin and start and piperacillin-tazobactam, start ceftriaxone. Continue the same antibiotics and change piperacillin-tazobactam to meropenem. Start ceftaroline. Okay, so 30% will go for just discontinue vancomycin. 26% will discontinue vancomycin, piperacillin-tazobactam, start ceftriaxone. Continue the same antibiotics, 22%, and change piperacillin to meropenem because the patient still have spikes of fever. Discontinue vancomycin, piperacillin, start ceftaroline. Hail, what do you think?
I'm happy to see the discontinue, leading. Here we have a diagnosis, a microbiologic diagnosis, and we have an antibiogram. The patient is spiking. There are many reasons. It can be a source control, an effusion or something, or drug fever, or there are many reasons for the spikes. But if the patient is improving, and we have a culture, then I'll go specific. A couple of weeks ago, I had more or less also Klebsiella pneumonia, and it was cefazolin sensitive. And I switched to cefazolin, actually. Patient did well. So I think...
The intensivist did not have a heart attack at that time?
Well, it was interesting, actually. We had I would not say a rough conversation, but it was kind of interesting. The acceptance was not there because what if? Always we have this question, what if? And if the patient is having spikes, maybe he wants caspofungin or anidulafungin or something, which is not uncommon. I mean, I'm not kidding. This is common. So, I think I will de-escalate here and treat this bug as it has been cultured and having sensitivity to us.
Tariq?
I do agree also with Dr. Hail. I think discontinuation of the vanco is very appropriate. Vancomycin would cover resistant gram-positives that had not been recovered here. And by the way, gram-positives that vancomycin covers are not difficult to recover in the majority of microlabs. In fact, everything in the lab, microlab, is set to pick up streptococci, enterococci, and MRSA. So we're not dealing with a brucella that could be hidden and kind of be seen, or TB or something like that. So I think it's very appropriate to DC vanco. And I think going with target therapy with ceftriaxone sounds appropriate. But since you've allowed me to comment, I would like to raise another issue. What about anaerobic coverage that has not been recovered, but because of intra-abdominal process, do we consider it, or we are just fine with the fact that Klebsiella is the only recovered microorganism and we're good with it? I mean, this is a debatable question. I'm not asking anybody in particular, but anybody is welcome to comment.
Any of the intensivists? Intensivist? فين راح؟ دكتور فين وفين ما اشوفه فين؟ No intensivist, only ID physicians. What happened to the intensivist? بدي agree, disagree from the intensive care?
هربوا منك دكتورة، قلت لهم أنا جاهزة لكم اليوم. They left the room.
دكتور لا ID physician ما في intensive care? No?
I will comment on their behalf, probably. There's this common argument or conversation between an ID physician and intensivist. And honestly, after so many years in practice, now I'm more into understanding why this is happening. And also it's happening with hematologists and all of the specialties where a high demand for antibiotic is there. the intensivists, they use a lot of antibiotics, and they feel comfortable using them. And they feel the infectious disease are more of restrictive in terms of, throwing antibiotics. In caring of a patient in the ICU, infection is one part. And this is where the ID is focused on, and thinking of this patient on resistance, and the next patient, and the third patient, and what comes in a month, what comes in a year in terms of resistance. So that's the focus of the infectious disease. The focus of the intensivist is getting this patient well as soon as possible to the floor or home. So the mindset is different, and I do understand it. And that's always the debate. I like people like Tariq, where he has both, and then he can adjust between the two mindsets. But I can see from where it's coming, and somehow accepting it, actually. But then we try to go into a healthy discussion on how to deal with this patient and still be safe, or convince the intensivist that it's safe enough, and then go forward with de-escalation, because the next patient, you need colistin or something really bad to treat him. But this particular patient probably will be well with only ceftriaxone.
Okay, Afrah.
What you have missed, guys, is what Dr. Afrah was saying, that the intensivists are privileged with continuous monitoring of these patients. So once they dip into, severity of illness and their health and overall illness is at risk, doctors can intervene. I would also agree with Dr. Hail for the third time by saying, yes, this is the mindset of the intensivist. When Dr. Huda was calling for an intensivist, when Jalis, I don't know what she's preparing, so I kept quiet. But I think it's good enough to say that the intensivists are trained, and remember, we debated this one time. Intensivists are trained to instantly attack, and then we attack with our antimicrobials. Just like we cannot tolerate hypoxemia, we instantly put oxygen. We can't tolerate hypotension, we give a fluid and inotropes, and we place central line and maybe an A line in an hour. And same thing, the fever, unfortunately, correlates to infection, which is not necessarily the right thing all the time. So, and that is why the antibiotics are being, in the way of that thinking.
Doctor? Mike,
I do not attend the session from the beginning, but it's very interesting. With my experience with the ICU for the past 16 years, in general, there is a tendency from the ICU personnel not to de-escalate antibiotic. This is seen. We practice both in ICU and we do de-escalate antibiotic, but for the ones who are trained in ICU, maybe the tendency to discontinue meropenem when there's full susceptibility pathogen, maybe another few days. What we did at National Guard, we did weekly meeting between the ID team and the ICU team, because not all ICU team expert in ID, and that maybe will have some impact on de-escalating antibiotic. This kind of meeting challenging to the ICU team that why you are keeping tazocin for the past 10 days if the pathogen is susceptible to ceftriaxone, for example. And we are facing a lot of MDROs big time. Candida auris is booming with significant morbidity and mortality in our ICU patients. So this kind of, challenging an approach, very important to have survival for our critically ill patient. So definitely de-escalating antibiotic is #1, should be target for all the ICU practitioner and the ID practitioner.
thank Thank you very much. Any other opinion? So the mention of fever, I just want to mention that the studies have shown that elderly patients may take actually 5 to 7 days for fever to disappear. So it's not the presence of a low, it's trending down, so it means that the patient is improving. We have a culture already that is sensitive. So I would choose also ceftriaxone like Dr. Hail and Dr. Tariq. طبعا this is a big fight with the intensivists because they will not love that and they will agree and they disagree on many things, but this would be my choice. I'll give you my second case. A 43-year-old man presented to emergency room complaining of 2-week history of progressive knee pain. Became actually worse over the past 4 or 5 days before admission. He had minor trauma to his knee prior to his complaint. He was complaining of fever, chills, and generalized malaise. He had medical history of hypertension and diabetes again. The patient was diaphoric and gross swelling of his knee with warmth in the right knee. He was febrile with 39 degrees centigrade. He was tachycardic and hypertensive, so the blood pressure is in. His white blood cell count, there is leukocytosis and shift to the left with 23% bands. He has elevated C-reactive protein and ESR. The patient was started on vancomycin. Blood culture were positive for gram-positive cocci in clusters 48 hours after admission. So, do you agree or disagree? Yes? You agree or disagree?
Yes, but this patient was started on vancomycin, and we have now gram-positive cocci in cluster. For this patient, despite he is at risk of pseudomonal infection because he is diabetes, but now we have targeted therapy, so we don't need to add another agent like ceftazidime. I think vancomycin is enough for this patient.
The bad luck is today and I found you. Zainab, Amira, Lujain. I'm going this way. Yalla. Any other volunteer? Muhammad. Oh, I forgot you. Sorry, Muhammad. Before you. Muhammad. You agree with the choice of antibiotics? Hail?
Thank you. I think here the scientific guess is probably narrow with the septic arthritis, and we know number one cause of septic arthritis is Staph aureus. The question with septic arthritis and what looks like Staph aureus in the blood, is it primarily coming from the joint or has been somewhere and settling in the joint? And always this is something to keep in mind because we've seen endocarditis manifesting in the joint. Again, going to data and your epidemiology, if you see a lot of community MRSAs, then vancomycin is the right choice. If not, which is, I think, would be debatable, then a special penicillin like nafcillin or cloxacillin, whichever you have in your formulary, will be good. Cefazolin also is acceptable. Until I know it's not MRSA, I think vancomycin is good. Then the other question will be how good vancomycin compared to nafcillin or cloxacillin in terms of dealing with Staph aureus, which I think it is inferior. Maybe in the blood, okay, but when it comes to a cryptic site, then I think the nafcillin, cefazolin, or cloxacillin will be a better choice. So again, we go to the status of the patient. If the patient is very sick, I give both, waiting for 24 hours, 48 hours to see it's MRSA or regular staph. And then I drop the vancomycin if it's a regular staph.
So you'll combine a beta-lactam with vancomycin. Dr. Tariq?
Anti-staph both.
Very much so. I think defining disease entity and pathophysiology, so obviously this is septic arthritis. I may drift a little bit and think more whether this was a primary bacteremia seeding into the joint, but perhaps perhaps from the story mentioned that there is nothing to make me preclude that. And then after knowing that this is septic arthritis, we follow what we know about the literature is that the gram-positives are more likely to be, and then Staph aureus is number one. And the third is defining our local epidemiology if we're dealing with MSSA more than MRSA. I think anytime when the local epidemiology indicate more than 20% of MRSA, then I think it becomes essential that vancomycin is being added. The practice of adding beta-lactam to vancomycin is something we've been tending to do more now compared to what we used to. For example, during my fellowship, which is like more than 15 years ago, we used to give vanco and then we were satisfied. Data have shown that no, certainly beta-lactams do better on MSSA than what vancomycin would do on MSSA. So we could be wasting more time, especially when we would know in no time what's the susceptibility. We already have the pathogen. We're just waiting for a day or two to know what the susceptibility is. I will combine. I will combine beta-lactam and glycopeptide.
Dr. Ali, will you combine?
Sorry. So I was saying that I share your concerns about the potential inferiority of a glycopeptide for Staphylococcus bacteremia with joint infection. I would throw in two things. These are gram-positive cocci on gram film. They could turn out to be coagulase negative staph and completely irrelevant to what the patient is experiencing. If I wanted really to target potentially Staphylococcus aureus, both methicillin sensitive and resistant, the option of combining a glycopeptide with an anti-staphylococcal penicillin was shown in camera, randomized trial, to be associated with excess acute kidney injury. And the study was discontinued early because of that. So if you think you're going to stop that after a day or two, maybe, but otherwise I think I would worry about that.
Yeah, actually earlier studies have shown that there is increased mortality with vancomycin alone, but later on tried to combine. They found actually there is disadvantage actually of combination. I used to combine until I saw that study. I stopped combining. So this is an interesting issue that I don't know if other studies or further studies will show again that combination is better. I'm not sure. Okay,
yeah,
so
I think to be committed to prolonged combination is not a good practice in my view. But this is well, if it's not coagulase negative staph, of course, I expect it to be Staph aureus. Then in 24 hours or maximum 48 hours, you will know, and then I think you'll be okay with both.
This is more of a broader coverage rather than directed therapy. So.
But the study was done because of the higher mortality with vancomycin for MSSA. So they combined vancomycin plus cefazolin, I think, and then they found out that it was not, or the increased nephrotoxicity, and the mortality was not different in those who combine with the non-combined in that study. So the recommendation was to stop combination. I'm not sure if anybody has a different opinion. So the orthopedic surgeon, sorry, I forgot to tell you. What other parameters we should do? Zainab Baqal. Can't hear you. Please, would you please raise your voice? Or since we're running short of time, yes?
Yeah, we'll do full septic workup for him. We'll do an directed ultrasound with an arthrocentesis. We'll do also an echo for him and to look where exactly the source of his culture. So
source control is very important. In this patient, the orthopedic surgeon was consulted and diagnostic arthrocentesis, and patient was taken to operating room for irrigation and debridement, which is very important in treating septic joint arthritis, that the orthopedic surgeon should go ahead and do their job also. The culture grew MSSA. So now you start your vote. What would appropriate manage this? Continue vancomycin and measure the level, so you make sure that adequate levels are obtained. Discontinue vancomycin and start meropenem. Discontinue vancomycin and start and add, continue vancomycin and add ceftazidime. Discontinue vancomycin and start daptomycin. And I can't find the one with cefazolin. Discontinue vancomycin and start cefazolin. كلكم عرفتوا الجواب because Hail said it. هاي اللي غششكم صح؟
But
100%? Oh, okay, we have
Very
3%.
no, we like that. In
هاي
fact,
اللي غششتهم.
it means we reached where we wanted to reach. It means we're good. So if you're convinced, after this discussion, I think mission accomplished.
Unfortunately, many people, they think vancomycin is a better drug than cefazolin. And because mainly it covers staph epi and so they think always, no, we don't want change. And when you tell them start cefazolin, يعني almost have a heart attack to that you will want start cefazolin because they said, no, this is a cheaper, first generation. What are you giving us besides vancomycin? So and I'll give you the data that support that cefazolin is better than vancomycin. So this,
Prof, if you allow me, I would like to ask a question that comes to mind of many. So if we give, say, cefazolin, and it's going to be probably prolonged treatment, this is septic arthritis, what are the odds of that MSSA picking up a resistant during a treatment that would require us to cover with vancomycin from the beginning, or that we have to think of changing to vancomycin thereafter? What are the chances that that MSSA would pick up resistant that is not only for septic arthritis, for anything? Peptazo-sensitive Pseudomonas in the lung. No, let's give meropenem because it may become resistant to peptazo. I mean, what is that chance? Maybe somebody from microbiology could comment.
We have Dr. Amani. She's our expert in microbiology.
Yeah, I think Dr. Tariq is referring to the inoculum effect here. Yeah, so that's what comes to the mind. I mean, I know the clinical studies have shown repeatedly that cefazolin is equivalent to anti-staph penicillin for those infections, for example, but in vitro data suggests that with cefazolin and any non-anti-staph penicillin can potentially have inoculum effect. Because now the clinical study is more in favor of cefazolin, we started arguing that in vitro data should make the clinician not use cefazolin just for that. But I think it again goes to the clinical assessment and reviewing maybe if the patient is not responding, repeated microbiological workup and cultures, and if the organism has shown resistance. And we have seen some interesting cases where heteroresistance actually occurred in cases of osteoarticular infection who were put on non-anti-staph agents.
Thank you. Okay, so these are our cases. I'll discuss briefly about de-escalation. Before that, I want to briefly mention why are we concerned about de-escalation. And this is mainly because antimicrobial resistant organisms. It's a global rise, a major concern by WHO, and it's going to be one of the world public health threats affecting humanity. Our use of large volume broad spectrum antibiotics coupled with poor infection control practices are the major driving forces behind increasing number of resistant strains in the health setting. This is a well-known slide. Everybody probably know that when we use antibiotics, we select for resistant strains. Not only that, the bacteria are becoming really smart and they transfer the genetic material between each other to give them the resistant genes. With our antibiotics, we're creating monsters like MRSA, carbapenem-resistant Enterobacteriaceae, and this is a major problem nowadays. We see it. Pseudomonas aeruginosa and Acinetobacter baumannii that are resistant to all antibiotics, especially in the healthcare setting. This is an interesting slide to show you between the time of development of antibiotics and development of resistance. If you look at the earlier antibiotics, it took actually several years for the resistance to develop. But when you look at the newer antibiotics, almost after a few months after development, antibiotics resistance develop. It's either our earlier antibiotics are stronger or our bacteria becoming really smart and they're becoming resistant to these antibiotics as soon as they develop. Stewardship programs is globally defined as any activity to optimize the drug selection, dosing, route, and duration of the antimicrobials. It implements direct and monitor appropriate antimicrobial use at the healthcare setting, and it provides a standard evidence-based approach to judicious use antibiotics. As already Dr. Hail mentioned and Dr. Tariq, we should know about likely pathogens. The local susceptibility data is very important in your hospital to know. Patient-specific factors such as allergies, severity of illness, and comorbidities. Risk factors for resistant organism. Did he receive antibiotics in the past 3 months? Like if you see a patient diabetic foot, he received multiple course antibiotics, your treatment is going to be different than somebody who is antibiotic naive. And then after we start our empiric treatment, we should escalate to the narrower spectrum that cover the pathogens. The good news is, if you look at the CDC 2019 report, I will focus mainly on the hospital-acquired organisms, we have less 18% death from antibiotic-resistant organisms comparing to 2013, 41% less VRE, 29% less multi-drug resistant Pseudomonas aeruginosa, and 21% less in Staphylococcus aureus. Also, we have less carbapenem-resistant Acinetobacter. Carbapenem-resistant Enterobacteriaceae are stable. So it is possible to be done. We just have to work hard to reduce the incidence of these infections. And what did they use in the CDC for the healthcare work? Mainly the bundles for the invasive devices, good infection control, tracking and improving antibiotic use. So this is what we are doing. So systematic reviews indicate also that antibiotic storage program decrease antibiotic use, antibiotic course, and duration of therapy, as well as local antibiotic resistant data. De-escalation, already Dr. Tariq mentioned about de-escalation. It's done in 3 ways. Once the culture is done, broad spectrum agents are changed to a narrow spectrum, or we can stop one of the administration components of the patient who was started on vancomycin, we can discontinue vancomycin, either stopping one of the antimicrobial agent that broadened the coverage, or the one that added for several organisms that we made, like for example, for VAP. And also, de-escalation is considered to decrease the duration of therapy to the shortest time linked to necessary to achieve optimal cure. I will not go through this. This is a diagram just showing you the bivital antimicrobials. And so, a few questions we have to answer with the de-escalation. The first question, is it safe? Looking at the studies where they publish, is it safe to de-escalate antibiotics? The non-blind randomized controlled trials was done by multi-centers, found no inferiority trials assessing anti-de-escalation versus continuation. So we know from this study that it is showed that it is safe to be given. In 20 observational study again, it showed that among them there is a difference in mortality were found not statistically significant in 14 study and significant decrease in the de-escalation arm in 6 studies. So but you have to be careful interpreting this result, because remember, most of the time, de-escalation is done for patients who are improving. So at 72 hours, you check the result, the patient is improving, then you can de-escalate. Most of the time, when the patient is not improving, de-escalation actually is not done. So we have to be careful about, does it really reduce mortality or not? And there is, as mentioned, Dr. Tariq, there is a lot of heterogeneity in these studies. For shorter duration, we know that we can use antibiotics for shorter duration, like in these entities. Okay, the second question is we want to answer, does de-escalation reduce the incidence of antibiotic-resistant strains? This is a bit more difficult question to answer. I have how many minutes? 3 minutes? 2 minutes, okay. So briefly, it shows no evidence that unfortunately the de-escalation changed the antibiotic resistance strain. And for several reasons. And like in this cohort study, they found that additional days of exposure to cefepime, meropenem, piperacillin-tazobactam was associated with increased development of resistance. Remember, most of the time we de-escalate to piperacillin-tazobactam or cefepime. We rarely de-escalate to penicillin or augmentin. So that's why probably we're not seeing a change in resistance with de-escalation. So this is our evidence. Unfortunately, it does not show the effect. Okay. The dark side. The dark side of de-escalation, unfortunately, it gives us this unwarranted sense of safety that anti-de-escalation should prevent the ecological consequences of extremely broad-spectrum antibiotics. I've seen it a lot in the hospital. Many times, patients with no risk of resistant organisms coming from the community, I found them on meropenem and vancomycin. And they always, the intensive will tell you, no, but I will change it. Once I know the organism, I will change it. Unfortunately, even for 72 hours, these antibiotics affect our microbiota and increases the risk for resistant strain organism. So this is very true. Many times I've seen it in the medical units, in the surgical units, that patients started on broad-spectrum aggressive antibiotics even with no single risk factor for resistant strains. Okay. Again, de-escalation is done in this study where they looked at the de-escalation from patients admitted with pneumonia. They found only de-escalation rate was 2 to 35%. So many times actually de-escalation is not performed in the ICU because of the reason that we already mentioned. Glycopeptide better than treatment of Staph aureus bacteremia. We already mentioned that. It definitely beta-lactams, whether flucloxacillin or cefazolin is better than vancomycin for the outcome. Okay. One point, I had to mention this before I go. What about escalation for patients who are not improving with gram-negative bacteremia? We see this a lot, and we fight a lot, and we do a lot of things in the ICU because of that. The intensivists insist, so patients who are not improving, and we already know the organisms, but they insist that we should escalate and we go for further, even if we know that it's sensitive to trixone. In this study, very interesting, they looked at the escalation for patients who are not improving. The total IV antibiotics days, of course, was higher in the escalation. The non-escalation, the long stay was also higher. What's more interesting when they looked, the incidence of nosocomial infection was higher in the escalation group, and the in-hospital crude mortality rate was also higher in the escalation group. So we think we want to save our patient, we're giving more antibiotics. It does not do that, actually do the opposite. It increases the hospital mortality rate, and this is probably because it increases the risk of nosocomial infection. So clinicians should be alert again, and patients are not improving to other strategies are already mentioned by Dr. Tariq, the sepsis. Most of the time is actually our immune system. The patient immune system is not working well to help us with the antibiotics, and it's not only the antibiotics. Alexander Fleming actually stated that he expected that resistance will develop even with development of resistance. I think the antibiotics treatment in the ICU should be team player, and I think it should be, the intensivist should be the one to carry out this, because if we do it, we'll be their enemies. But if they do it from their side, I think we'll be more of a team that will help each other in controlling antibiotics usage in the ICU. Thank you very much. I think this was the fastest lecture I gave in 5 minutes.
Excellent. Thank you, Prof. Any quick question, comment? We're closing in half a minute this session. Okay. Yes, Dr. Mustafa has a comment. We can't say no to Dr. Mustafa. He's after all this. Yes, the mic is behind you, sir. Sure.
Well, thank you, Dr. Huda. I just want to say, I think we can utilize some of the newer diagnostics to help us de-escalate. Like one of the, let's say about the second case with the bacteremia, with the gram-positive. Nowadays, I think many hospitals have like the multiplex PCR, where we can get the identification of the pathogen within hours. So on the same day, you can decide on having the patient on the proper antibiotics. Probably some other hospitals have also now MALDI-TOF. Again, you can get the identification of the pathogen very quickly. That would be of a great help to de-escalate and give the patient adequate therapy immediately without delay. So this is my comment. Thank you.
Actually, many studies looked at that. They're using the sequencing studies and the multi-TOF, and they were able to de-escalate. But you see, it's again, sometimes we have the organisms in cultures. It's not even in the, and we have difficulty in the escalation. So it is, I think it should be, this is something has to be led by the intensivists, that they really want to reduce. It was proven that de-escalation reduces cost because it is less expensive antibiotics. And so this is one, if we go to the hospital administration, that is less cost to the hospital, it may be pressurize the intensivist to de-escalate more.
I think resistance in microbes is inevitable. It will happen. Whatever we do, it will happen. It just, we want it to happen sometime in the future, maybe somebody else to deal with it. And this is a war, so we have to manage it smart. And part of this smartness is the de-escalation approach.
Thank you all. I think we close. Thank you so much.
Thank you very much.
It was an outstanding interactive session. I would like to thank Dr. Tariq, Dr. Hail, and Prof. Huda. Please, Dr. Zainab and Dr. Mustafa for recognition of Dr. Hail Abdali.
Bismillahirrahmanirrahim. Welcome everybody. So we'll start with the first speaker, Dr. Ali Al-Amrani. Dr. Ali is a senior consultant in infectious diseases at Hamad Medical Corporation and the clinical professor of infectious diseases at the College of Medicine, Qatar University. Dr. Amrani has a clinical and a research interest focus on the management of infection caused by multi-drug resistant pathogens and infection in immunocompromised hosts. He is a frequent speaker at national and international medical events and is a lead author on numerous original research articles, reviews, and editorials. Dr. Ali, well known, and I had the honor to be one of the trainees under his supervision. Dr. Ali.
Thank you very much, Tar. It was my pleasure to be working with you one day. Assalamu alaikum. Thank you, Mustafa and Dr. Zainab, for the opportunity to join you. I did join you virtually last year, but it's even better to be here in person. I was asked to talk about management of resistant gram-negative infections, and I'm conscious that the next one is going to talk about gram-positives. So I hope between the two of them, you get some update. Now, whether it's gram-positive or negative, the more resistance the things are, obviously. And people have introduced terms such as multi-drug resistance and extreme drug resistance and even pan-drug resistance to express how resistant a pathogen is from a microbiology or from an in vitro point of view. The less agents available, obviously, the less available for clinical use. This more recently has been replaced by difficult to treat, but I'll come back to that in a minute. But obviously, if you have fewer and fewer treatable options, usable options, you're going to reach out to less effective options, potentially more toxic, and obviously those are less effective, and that's why they were left behind. So if you have more resistance, you're more likely to experience, or your patient is more likely to experience treatment failure. And obviously that includes losing patients every now and again. Now the term difficult to treat, I find from a clinical perspective much more friendly and much more meaningful and relevant. What difficult to treat reflects is an organism that is not susceptible to the agents that you really want to use. So if an organism, gram-negative, is resistant, for example, to all available beta-lactams and quinolones, you're obviously going to use less effective or more toxic agents. And when this term was introduced by Qadri and his colleagues in Boston, the first thing they did was to look at a very large database of gram-negative bugs. And within those, they found that the proportions that were resistant to third-generation cephalosporins and carbapenems were there, but even smaller was a proportion that had no options. And if you reflect back to your own clinical care, you will find that this happens very often, where the lab, say, reports a Pseudomonas resistant to carbapenems, but you shrug your shoulders because it's sensitive to ceftazidime or to beptazo. So although it is multi-drug resistant, but in terms of choices and options to treat, that's not difficult. So what matters more from a clinical perspective is how difficult is it to treat. And interestingly, in the same paper, they were able to show that if a bug was difficult to treat, that independently was associated with increased risk of treatment failure or mortality in this situation. And the more, the number of active agents you had out of carbapenems and fluoroquinolones was a good thing. So in other words, from a clinical perspective, it would be nice if we start to think about difficult or not too difficult to treat rather than necessarily MDR, XDR, which are mostly useful for surveillance purposes. Now, if you're running out of agents, then the smart thing to do would be to develop new ones. And we've been fortunate in the last 10 to 20 years to have many, many agents introduced. Most of them are beta-lactams combined with beta-lactamase inhibitors, but there are also one or two potentially novel antibiotics. Now again, reflect back about what is it exactly that you want to use those antibiotics for, and what is it that you want to treat. Now thinking about gram-negatives and mechanisms of resistance, most of it is mediated through beta-lactamases. Of course, porin loss, upregulation of porins is important, and of course, efflux pumps are important. But the simplest to talk about are beta-lactamases. And the beta-lactamases, for most of you, would be those 4 classes, A, B, C, and D. But again, think in terms of difficulty or ease of use in terms of treatment of a target organism. And if you look at those potentially new agents, and then you look at where they help and where they don't, you see very quickly that they're not very helpful where a metallo-beta-lactamase is involved, a class B beta-lactamase, or where what you're dealing with is a difficult to treat Stenotrophomonas or carbapenem-resistant Acinetobacter. Most of these newer options would help us with things like third-generation cephalosporin resistance and maybe certain carbapenemases belonging to certain classes. Now, because we spend most of our time thinking about choices to treat patients with carbapenem resistance, we think that that dominates the world, but that's not the case. Most clinical impact associated with gram-negative resistance is actually because of resistance to third-generation cephalosporins, and that's mostly ESBLs and AMC enzymes. This is a study from Europe. It's a very large surveillance study. And what they did is they looked at an association between type of resistance and clinical outcomes. On the x-axis, you're seeing a number of individuals who died in association with this particular resistance phenotype. And the bubble, the size of the bubble, reflects the effect on quality-adjusted life years. So if I circle third-generation cephalosporin up there, you could see that the organism that causes most problems for our patients is not the carbapenem resistance. Actually, carbapenem resistance is down here. So in terms of magnitude of effect, it's actually cephalosporins, third-generation cephalosporins, ESBL producers and ESBL and AMCs. It's those two that cause most of our problems, followed by carbapenem resistance in Enterobacterialis and Pseudomonas, because these are virulent organisms. Lesser of a problem in terms of clinical impact are things like Acinetobacter, because just the organism is not as resistant as you think. So now going forward, what I'd like you to do is to think about gram-negative resistance in terms of how difficult is it to treat, and think of it in 3 levels. Cephalosporin resistance, followed by carbapenem resistance, but without a metallo-beta-lactamase, and then carbapenem resistance in the presence of a metallo-beta-lactamase. So if we start first with ESBLs, we know that the Merino trial showed that beptazo is not inferior
to a carbapenem for treating ESBL-producing organisms when they cause bacteremias. And when these results were first published, some questions were raised because everyone who died in this study died because of a non-infectious reason. So there was some discussion as to whether beptazo is truly inferior to carbapenems or not. The follow-up studies from the same set of organisms actually clarifies what went wrong. So what happened in Merino was, it was supposed that patients would be randomized in Merino to meropenem or beptazo if they had an ESBL-producing organism causing bacteremia, as long as the lab reports this organism as susceptible to both beptazo and meropenem. So theoretically, everyone who was recruited and randomized in this study had an isolate that was susceptible to beptazo. Post-study, the organisms were all shipped to a reference lab down in Australia where they were retested. And what you're looking at is the MIC distribution for beptazo on your right-hand side and on your left-hand side, meropenem. And you can see very quickly that a lot of organisms were classified as susceptible, but they were not. And that is something you need to realize. Particularly clinicians among us you need to realize that sensitivity and resistance is not as black and white as you think. It's subject to many things, including where it was tested and how it was tested. And the level of accuracy that you would get from a routine diagnostic lab is not the same diagnostic accuracy that you get from a reference lab. So you shouldn't be all shocked and raising your eyebrows over this. It actually happens. You just don't know how often it happens in your day-to-day diagnostic clinical work. So many of these isolates were actually resistant. And then the question comes, so is it that those who failed on beptazo failed because of resistance? And the answer is actually no. The first thing they did is they looked into the underlying genotypic mechanisms associated with this beptazo resistance. And interestingly, most of it was an association of an ESBL or an AMPC plus narrow spectrum OXA enzymes, which are class D, mostly OXA A. So when you have more than one beta-lactamase, even if individually they might have a narrower spectrum, working together they can have a broader spectrum. But that's not the point. The point is that when they analyze the data again, reclassifying those as resistant, as properly resistant or not, this non-inferiority was still not demonstrated. Saying it differently, if you have an ESBL-producing organism causing a bacteremia, you cannot use beptazo. These data are now conclusively ruling out beptazo, and it means carbapenems would be used if you want to use a beta-lactam. The next type of enzymes that are not very well understood in my experience are AMP-C enzymes, and I'll spend some time on those. So AMP-C are class C enzymes, and what they do is they're present constitutionally in chromosomes of some bacteria, for example, Enterobacter. Enterobacter is a very good example of that. And they're present on plasmids in some other bacteria. When they're present on plasmids, they don't behave the same way. So everything I'm going to say now is about chromosomally mediated AMP-C. If it's carried on a plasmid, say if you detect it in an E. coli, for example, then everything I'm about to say now is not applicable. So on a day-to-day basis, bacteria live their life around and they recycle their cell wall. And when they recycle their cell wall, they produce side products. And obviously they need to mop these away and clean up. And to do that, they use AMP-D. So these products are cleaned by AMP-D and then they're gotten rid of. So that's what happens on a normal day-to-day basis. If you use an antibiotic that we call an inducer, it wasn't created to be an inducer, but that's what it does. An antibiotic such as ampicillin or amoxicillin or cefoxitin. What these antibiotics do is they produce a lot of these side products to a point that they overwhelm the system, the AMP-D system. So it's no longer able to suppress or repress the AMP-C production system. So what you see here is induction. Suddenly there's a lot more AMP-C than there is in the background. So if you take this bug and test it for susceptibility for an antibiotics like ceftriaxone, it could appear susceptible because it's not producing a lot of AMP-C. But once you expose it to an antibiotic that can induce AMP-C production in a human being, such as ceftriaxone or cefoxitin or amoxicillin, then you see extra production of AMP-C, and then the organism switches phenotype and it becomes resistant. So where is this important and why? It's important if you're treating an organism that you know possesses a chromosomal AMP-C. Even if the phenotype is not showing resistance to certain agents, you may want to avoid them because you would worry about the effect of induction. Some antibiotics are strong inductions and they're also substrates. And again, cefoxitin and amoxicillin are very good examples. Some are very strong inducers, such as imipenem, but they're not substrates, so it doesn't matter. So when you give imipenem to an AMP-C producer, it does result in a lot of induction, but it's not affected because AMP-C is still active against AMP-C producers, imipenem is. If you use something like cafepime, cafepime is a weak inducer and it's not a very good substrate, so it may work, it may not work. So the relationship depends. Where questions continue to linger is on biptazo, because piperacillin and tazobactam are weak inducers and they're not very good substrates. So would biptazo work on an AMP-C producer if it was susceptible in vitro? And the answer is we don't know. And then you've got another type of AMP-C that you need to understand, and that is when you lose this repression. This becomes a de-repressed mutant. This is when it loses the AMP-D function altogether. So what it's doing right now, it's producing loads and loads and loads of AMP-C all the time, even without any induction. These are not very difficult to detect in vitro because they're obviously resistant. However, they could be selected under antibiotic pressure, and Professor Huda was talking about selection pressure in the previous talk. So if you were, for example, to use a third-generation cephalosporin, potentially even amoxicillin clavulanate, you could select de-repressed mutants and these become more evident. So what I was trying to say to you is this. This is a randomized trial that is currently recruiting to answer the question about biptazo and AMP-C. Can we use other antibiotics other than carbapenems for ESBL producers? Well, based on this randomized trial, ceftazidime avibactam seems also to be an option. So going forward, what I would like you to remember is this, if you've forgotten everything else I've said. What matters most in terms of gram-negative resistance, in terms of impact, is resistance to third-generation cephalosporins. And that is a marker for resistance mediated mostly, not always, but mostly, through ESBL enzymes and AMP-C enzymes. And the treatment of choice for those organisms is still a carbapenem mostly. But if it's susceptible, then you may use a quinolone, and in certain sites and in certain situations, maybe even trimethoprim sulfamethoxazole. In terms of newer agents for these organisms, well, they are obviously active, and there is some clinical data to support them. But the guidelines that offer them still say this with a pinch of salt. They say, well, these are too expensive to be used for ESBL producers and AMP-C, so maybe you want to reserve them for something else. If I had time, I would have talked to you more about the cafepime issue and why it's controversial, but all these three guidelines do not support or recommend cafepime for these organisms, so leave it aside. So you've got choice, and although these are slightly more difficult to treat, but they're still treatable. And I'm sure all of you have access to carbapenems and quinolones and Septrin. And then you have carbapenem resistance, which is, as I said, is a different level. It's the next level. But it's not all the same, and it's not all the color. So you have carbapenem resistance that is mediated through carbapenemases, and you obviously have carbapenem resistance without carbapenemases. When a carbapenemase is present, the least you should know is what type of carbapenemase it is. At least, is it a metallo-beta-lactamase or not? Because that impacts immediately on your treatment options. An example would be ceftazidime avibactam, which I hope that most of you have access for. And that is active against those that produce carbapenemases in class A, like KBC, or in class D, like OXA48 and OXA48 likes. But it's not active against metallo-beta-lactamases. Some of the other new beta-lactam, beta-lactamase inhibitors are mostly, again, active against class A, but they're not active against class D. I'll come back to cafidericol later. It's an interesting antibiotic, but everything that is interesting also potentially brings in interesting problems. So one of the common misconceptions in our region is that OXA48 dominates as the carbapenemase, which is actually not true. If you read Western literature, they will continuously say that OXA48 is common in the Middle East, and that's true. But when you look at the proportion of carbapenemases in the Gulf region, the larger proportion actually belongs to metallo-beta-lactamases. They're mostly New Delhi metallo-beta-lactamases, NDMs. Kuwait in particular has a high proportion of VIMs, but VIM and NDMs are all class B, alone or with something else. So 50% of carbapenemase mediated carbapenem resistance in Enterobacterales that you will come across is actually because of an MBL. It's because of a metallobeta-lactamase, not ALAHSA. There were ABCs at all during these isolates. We looked at similar set in Qatar, and it's exactly the same story. The only difference is we saw some KBCs, but those KBCs were imported in patients who had transplants elsewhere. It's also something I want to draw your attention to, which is the proportion of isolates that are carbapenem resistant without a carbapenemase, because those obviously are still no MBL category. So whether it is a carbapenem resistance mediated through metallobeta-lactamase or not affects the choices that you can make. And these newer beta-lactam, beta-lactamase inhibitors have now accumulation of clinical data to support their use. But like everything we've used and misused in the past, they are at risk of resistance emerging with excess use. Some of it, as Hayal said a little earlier, is inevitable. It's just a case of slowing it down. But if you use them more appropriately, then at least the price we pay for that resistance is understandable. So in this small study, what they were trying to show is use of these newer agents was associated with emergence of resistance. And in a different opportunity, I can talk to you about what types of resistance to predict depending on what you use. But that's not the point now. And I'll skip the imipenem relibactam role here as well. So if you had a non-MBL producing Enterobacterales, what options can you use? Well, the obvious one is to choose the old antibiotics if they are susceptible in vitro and if the clinical site is appropriate. An example would be tigecycline for a soft tissue infection. I'm not suggesting you use tigecycline for a pneumonia or a bacteremia at any dose. So if the site is right and it's in vitro susceptible, then these old agents are useful. If there is a carbapenemase that you've identified is not an MBL, then ceftazidime avibactam is useful, as long as it's susceptible in vitro. I don't know whether you have access to meropenem vaborbactam or imipenem relibactam, but these are options for KBC producers. And then you've got things like ceftolozane tazobactam, which is not an option because it doesn't work. And then we have colistin. And colistin is something I'll come back to, but it's useless and it shouldn't be used really unless you have nothing else to use whatsoever. If it's a pseudomonas, and again, you've shown that it's not an MBL producer, then it tends to be because of something other than a carbapenemase, and therefore other active beta-lactams are your first choice. Other than that, you can use old agents or you can use some of the newer agents as long as they're active in vitro, and polymyxins if you have nothing else to do. Cafidaricol, as I said, is a new antibiotic, relatively speaking. It's a Cidre4 analog, so it tricks the bacteria into thinking it's carrying in iron, but what it does is it brings in the cap cell, and then it allows. In randomized trials of nosocomial pneumonia and UTI, it was okay, but when it was tested in the organisms that we are most troubled by, carbapenem-resistant bugs, it didn't do so well. Incredible CR, patients with infections caused by carbapenem-resistant gram-negatives, whichever that infection is and whichever bug it is, were randomized to either receiving cafidaricol or receiving the best available therapy chosen by their treating physicians. And what was shown in this study was there was excess mortality in the cafidaricol arm. When you look at cafidaricol on paper, it looks fantastic. It's active against all 4 classes of beta-lactamases, and it's active against even carbapenem-resistant Acinetobacter and Pseudomonas. It looks superb. But in clinical trials, when used for carbapenem-resistant bugs, it didn't do as well as we would like it to, and there was an obvious imbalance in mortality. And the question then comes, well, obviously these were heterogeneous infections and heterogeneous bugs, but was it because of a failure of a drug or was it something else? So to judge that, what the investigators did is they brought in an adjudicating committee. It was a completely independent committee that reviewed the data. And they asked them, do you think these failures were because of the failure of cafidaricol? And do you think those excess stats were because of the cafidaricol? And the answer in most cases was yes. And this is by an independent adjudicating committee. So it appears that cafidaricol can be associated with some risk of mortality, excess mortality. And one possible explanation for that is undetected heteroresistance. Again, if I had more time, I would talk about this, but it's simply that when you test for resistance against cafidaricol at baseline, you don't detect it. But if you do additional specific testing, you can identify subpopulations of bacteria that could be resistant. And obviously, under treatment pressure, those would emerge. So is it that those excess treatment failures are because of heteroresistance? Well, that's possible. Last, and I'm not going to say last but least, it's actually last because it's last, is colistin. Now, everyone has tried to pump some life into this antibiotic that died in the late 1960s, and it just hasn't worked. For the last so many years, people have tried to optimize the dosing. So many population pharmacokinetic studies in so many different populations, and I don't know how many now versions and updates of colistin dosing recommendations, and it's still the same. It's always inferior to anything else that it's been compared with. It's always more toxic than anything else. If you look at the latest version of dosing recommendation, which distills the wisdom and understanding from multiple agencies and societies from around the world, those regimens were based on target attainments of less than 2 steady state average colistin levels for Pseudomonas and the same for Enterobacterales. But as you all know, recently these breakpoints were changed, and now Pseudomonas breakpoint is 4, and CLSI have removed susceptible category altogether from colistin because they think it's not attainable. So the best you can do with colistin is reported as intermediate. What does this all add up to? Well, it adds up to you recognizing that colistin is not a drug that you want to use for yourself or any patient, as long as you have an alternative. Obviously, if you don't have any alternatives, then you're not left with much choice. Inhaled colistin potentially has some role if you're treating pneumonia, but you need to use the right nebulizer and you need to use a lot of it, at least 4 to 7 million units. So if you have an MBL producer, your choices become less and less. One option is to use this combination of aztreonam with avibactam if you have access to those. Most of us use old antibiotics, and most of us find ourselves desperate enough to use colistin very reluctantly. Last, Pseudomonas, the picture is not very different. So with this, I'll go to this. What should you do really if you want to treat a multi-resistant gram-negative? Well, the first thing I think, and the guidelines think, is that you should try to use a beta-lactam. A beta-lactam that is in vitro active. If in the initial stages you want to combine it with something like an aminoglycoside because you're waiting to confirm susceptibility, then that's fine. But if you want to combine to improve efficacy, then you're wrong. If your patient cannot take a beta-lactam, or a beta-lactam that is active is not available to you, then an alternative is fluoroquinolones. But as you know, most of our multi-resistant, extreme resistant are actually resistant to quinolones. That becomes a problem. And then you start to look at the smaller font, including things that you don't use very commonly.
Thank you, Dr. Ali. Our next presentation will be about the updates on resistant gram-positive bacteria. This is going to be held by Dr. Reem Al-Mahasna. She's a clinical pharmacist specialized in infectious diseases in King Fahd Specialist Hospital in Dammam. Dr. Reem earned her Doctor of Pharmacy certified from Imam Abdurrahman bin Faisal University, and she's joined the residency program at King Fahd Specialist Hospital in Dammam. This was followed by the infectious diseases training King Faisal Specialist Hospital and Research Center in Riyadh. Dr. Reem has got the American Board certified in pharmacotherapy as a pharmacotherapy pharmacist and certified as antimicrobial stewardship by Society of Infectious Diseases. She is a project co-leader for the antimicrobial stewardship program implementation in the Eastern Health Cluster Hospitals. So let's welcome her.
Assalamu alaikum rahmatullah. Thank you very much for introducing me, and thank you AIDME committee for the invitation. So as Dr. Ali mentioned or talked about the gram-negative, we'll move on to cover the resistant gram-positive bacteria. So I would start with a brief epidemiology, then focusing on the MRSA mortality in ICU patient, and should we use the anti-MRSA as empirical agents or not? Then what are the agents available? How it was compared in terms of efficacy and safety, and then should we use it as monotherapy versus combination, which is the new emerging discussion. So as what was mentioned before with my colleagues, that according to the 2019 CDC antibiotic resistance rate report, it was categorized into urgent, serious, and concerning. And luckily, all the gram-positive bacteria, including MRSA, VRE, and drug-resistant strep pneumo, all were classified as serious, with MRSA having the highest rate of mortality and acquiring the higher cost or the higher healthcare cost. When we look at the data in Saudi Arabia, there are multiple reports studying the prevalence in multiple regions of Saudi Arabia. The highest MRSA, as you can see, was in the western, followed in the central, and luckily the least is in eastern province, acquiring around 27%. The highest rate of MRSA was healthcare associated rather than community acquired, and it was mainly up to 45.5% in critical care setting. Luckily, almost all the isolates were still susceptible to vancomycin, linezolid, daptomycin, and tigecycline. When it came to VRE, reported prevalence is still lower, acquiring up to 17.3%, and the most common is the well-known Enterococcus faecium. Also, it was higher in ICU setting, with blood being the commonest source, up to 74%. So when we look at the Surviving Sepsis Campaign 2021 recommendation, the best practice statement is that for all adults presented with sepsis or septic shock at higher risk of MRSA, they should be started on anti-MRSA regimen, which is a broad-spectrum empirical treatment. What are the risk factors according to the guideline and the studies? It was the prior history of MRSA infection or colonization, history of recurrent skin infections or chronic ones, hemodialysis, having invasive devices, recent IV antibiotics, and recent hospital admissions. But on top of all of this, what's the likelihood that my patient could have infection secondary to MRSA, which is mostly related to the site of infection? When we look at the other side, which is the harm associated with withholding MRSA agents in patients who end up to have MRSA, to start with, the 30-day mortality in ICU secondary to MRSA infections was observed to be 31 to 43%. And if you look at the chart, it was significantly higher among patients who received inappropriate empirical therapy as compared to those who received appropriate within the first 48 hours. Looking at the appropriate, vancomycin was the commonest anti-MRSA agent used, up to 86.9%. Also, we should think of the harm of adding MRSA to the empirical regimen when it is not needed. It was also associated with a higher mortality and the most commonly the risk of toxicity, including C. diff and kidney injury. So it's a difficult decision when to consider adding or not adding, as both are associated with harm to the patient in ICU. So if we look at the available agents or that was studied to treat gram-positive infections, our first and the standard of care is vancomycin, which was approved in 1958. It remains in the market for 44 years as the only available agent to treat MRSA. Later, after 44 years, we had linezolid. Then it comes daptomycin, followed by ceftobiprole, which is not yet approved by the US FDA, then ceftaroline, and finally the lefloxacillin. So how are those agents compared according to the available literature, and which anti-MRSA should be started for my patient? So vancomycin remained the mainstay of therapy for the treatment of serious MRSA infections. Should it be? Vancomycin clinical success is much more complex than what we think. We have to think of multiple things before starting the patient on vancomycin. It is the standard of care. However, starting with the MRSA MIC of vancomycin, are we using both microdilution or we are using e-test, as there is a great discrepancy in the interpretation of MIC between both? the dosing. Should I use the standard dose or should I use patient on kinetic to calculate the doses? What's the site of infection? Does vancomycin reach with a good level or not? Should I use AUC versus trough monitoring and how it correlates to the nephrotoxicity? If I used one of them, what's my optimal target? What about using vancomycin in special population like obese, pediatrics, neonates, and elderlies? What's the nephrotoxicity that are associated with vancomycin? We know that it is high, but does it overcome the benefit that we are having of vancomycin? All of these questions are still not clearly answered. So the question is, this year, vancomycin is approaching its 65th anniversary. Is it time to consider retirement of vancomycin? We have to compare it to other agents and see how they are compared. Are they similar in efficacy, safety? Should we start the patient on these agents instead of vancomycin? We know that nearly 97% of Staph aureus isolates are remaining susceptible to vancomycin, as visa rate is still low as compared to the other bacteria. Also, studies report that vancomycin has approximately 5 to 20% persistent bacteremia rate, which is very concerning nowadays. So in addition to this, vancomycin, when it was compared to other agents, it was associated with higher all-cause mortality. Also, it was associated with higher healthcare cost, including the cost of the medication, the pharmacist who will do the TDM, and the cost of the testing and repetitive levels. So it was much more costly as compared to other agents. So with all of these issues, should we delete again vancomycin or not? So the first one that came after vancomycin is linezolid. Linezolid was compared to vancomycin specifically or mostly focused in pneumonia, including ventilator-associated pneumonia. One study showed that linezolid presented a significantly higher concentration than vancomycin in ETT biofilm. So what we are seeing in practice, mainly the interventionists, they are asking for linezolid when the patient is not improving on vancomycin, claiming that it would have higher concentration. So that's why studies also showed that linezolid was superior to vancomycin in improving clinical and microbiological success in pneumonia and also in skin and soft tissue infection. 30-day mortality between them is still controversial. Certain studies showed that vancomycin was associated with higher mortality as compared to vancomycin, whereas others showed that there is no difference between them. In terms of safety, we all know that linezolid is associated with higher risk of thrombocytopenia. The benefit, but outside the ICU, is that linezolid is BO option, so we can discharge our patient on BO when it is indicated. So multiple studies, again, as I mentioned, compared the use of linezolid in ICU as compared to vancomycin and MRSA and as compared to daptomycin and VRE, bacteremia and endocarditis. Some studies showed that there is no difference between them, others supporting linezolid and other studies supporting the other agent, which is vancomycin or daptomycin. So when we talk about daptomycin, the first trial comparing both was in 2006. It was non-inferiority trial that used daptomycin dose of 6 milligram per kg only as compared to the standard of care, either vancomycin or anti-staph penicillin, depending on the susceptibility of Staph aureus. As we can see that daptomycin was not crossing the non-inferiority margin, so this study was concluding that daptomycin is non-inferior to the standard of care for the treatment of bacteremia and endocarditis caused by either MSSA or MRSA. After that, multiple retrospective propensity score matched studies came comparing daptomycin versus vancomycin. In all of these studies, the daptomycin dose was averaged at 8 milligram per kg, noting that the vancomycin MIC in all studies was 2 or less. ICU patients were comprising a high up to 73% of the patients on those studies. These studies showed that the clinical failure was significantly lower with daptomycin, which is around 29% versus 48% with vancomycin. It also showed that there is a reduction in 30-day mortality with daptomycin as compared to vancomycin, with no significant difference in the length of bacteremia clearance between both. Safety-wise, we know again that daptomycin can increase the CK level causing myopathy. However, studies showed that the level of having significantly high CK is still around 1 to 2%, which is rare, whereas the rate of experiencing non-significant increase accounting for 30%. As I mentioned earlier, daptomycin is considered cost-effective when compared to vancomycin. So if you can see here, regardless of the source of bacteremia, daptomycin was associated with higher clinical success as compared to vancomycin. Then we have our third agent, which is ceftaroline. Ceftaroline was compared to vancomycin, but mostly to daptomycin in the literature, either as monotherapy or as a combination with daptomycin. So multiple studies report that there is a clinical success of using ceftaroline for serious MRSA infections. When compared to daptomycin, it was having comparable efficacy, as they were having comparable composite failure, comparable mortality, with comparable bacteremia clearance. The safety of ceftaroline, it's very safe when it's used less than 7 days, even though if it used more, the toxicity anticipated is rash and neutropenia. Then it came the role of combination. As the discussion before, it was mentioned that vancomycin was compared as monotherapy versus multiple agents, including rifampicin, gentamicin, or anti-staph penicillins. So we have multiple studies. For the sake of time, I'll not mention them. All of them were associated that the combination was associated with higher mortality, harm and toxicity to the patient with no added benefit in bacteremia and endocarditis. The most successful combination was daptomycin with ceftaroline versus monotherapy of either vancomycin or daptomycin. Actually, the combination of daptomycin and ceftaroline was associated with a total duration of bacteremia 9 versus 5. We can see that the combination has higher clearance, but this is because they added the ceftaroline on top of the started agent after failing of the clearance. The time to blood culture clearance was comparable as well. The combination was associated with lower incidence of clinical failure, lower recurrence rate, and higher MRSA-related death within 60 days. However, the longer, within 90 days, there was no differences between them, with no statistically significant difference in terms of safety. All of these combinations were studied because we are having the emerging persistent MRSA infections. When we look at the persistent, how it is defined, still we don't know. Is it after 1 day, 3 days, 5 days, or even 7 days? There is still no clear definition. However, we clearly know that each day of or each extra day of having a positive culture would increase the mortality by around 16%. So this is an algorithm suggested by a recently published article. It said that whenever a patient diagnosed with MRSA bacteremia, he could be started with vancomycin or daptomycin 8 to 10 milligram per kg per day. And then if we are repeating after 24 to 48 hours the blood culture, if it came positive again, this is a worry point. We should consider, is it persistent? Is it complicated bacteremia? Is there a complicating site? Then whenever repeating after 3 to 5 days, if it came positive again, this is the flagging or the red flag that we should think of adding an extra agent or switching to an agent. But the question is, should we add or switch? It's not yet clearly answered. We have newer agents, including ceftobiprole and lefloxacillin. However, still it wasn't studied in ICU patients. Ceftobiprole is approved for the treatment of community-acquired and hospital-acquired, but not ventilator-associated pneumonia, as it was associated with lower cure rate. Lefloxacillin is approved again for community-acquired pneumonia and skin and soft tissue infection. This is a new fluoroquinolone. It has in vitro activity against MRSA and Pseudomonas. As compared to other fluoroquinolone, it has lower drug-drug interaction and better safety profile. But still, there is no clear data if we have a role in higher or much more serious MRSA infections for this agent. What about VRE? I covered the MRSA management. When it comes to VRE, for years we know that linezolid, daptomycin, and tigecycline have been the mainstay of therapy for VRE facium infections. When we compare linezolid versus daptomycin, again, there are no stronger studies to compare both. Some studies showed that daptomycin are much better and others were with linezolid. However, still, we don't know which agent should be started for which patient. However, for refractory VRE facium infections that failed the traditional, here again it came the role of combination. Whether should we use, for example, daptomycin with beta-lactam, which is again the most successful combination, or we should switch to another agent. So the take-home message from this is that MRSA and VRE prevalence, we know that it is lower now as per the latest CDC, but it will continue to rise throughout the years if we are continuing our malpractice in terms of overuse and misuse of antibiotics and adding especially the vancomycin when it's not needed. It might end up the patient having VRE afterward. Screening of ICU patient is highly indicated for both VRE and MRSA. After screening, if the patient is MRSA colonized, what's the role of decolonization in ICU? Should it be a universal practice or targeted practice? The choice of agent to treat VRE or MRSA will depend on the patient's own risk factor, the infection, and the comorbidities that he's having. When we think of it, when should we change the antibiotic if the patient persisting? Should I use monotherapy versus combination? All of these need further studies, and here it came the role of antimicrobial stewardship physician and pharmacist to try to de-escalate, as Dr. Huda already mentioned, or try to choose the best agent for the patient by the end. Thank you very much.
Thank you, Dr. Reem. Now we'll move to the next speaker, Dr. Amani Al-Nimr. She's an associate professor, College of Medicine, director of clinical microbiology residency program, and Imam Abdulrahman bin Faisal University in Dammam. She's a consultant of clinical microbiology and infection control at King Fahd University Hospital, Al-Khobar. Dr. Al-Nimr obtained her MD degree from King Faisal University, Dammam. Then she pursued her Master of Science of Clinical Microbiology at Queen Mary University in London. She gained a PhD in Infection, University College London. Then she got her postgraduate diploma in Academic Practice and Medical Education, University of Liverpool. Dr. Amani presented at several international and national conferences in the specialty. She has more than 40 publications in peer-reviewed journal with a particular research interest in the clinical utility of laboratory assay and infectious diseases. Dr. Amani, she will talk about the newer diagnostic tool in managing serious infection in a patient in ICU. Dr. Amani.
Assalamu alaikum and good afternoon, everyone. Thanks, Chairs, for the kind introduction and to the organizing committee for having me here and for proposing this hot topic. So what newer tools we have to manage ICU infections and why? We'll focus on two types of infection, bloodstream and respiratory tract infections. The reason is because most of the advanced tools have been developed for these two types of infection, and also you have a varieties of options in the market, and most of the data and the literature are regarding those infections. And then we will wrap up by proposing a model of success and home messages. So this is your ICU patients who typically have multiple factors that predispose them as infections. And the problem is routine microbiology results come late, leading to delay in initiating targeted therapy. If you don't know your enemies, it can be sometimes hard to tackle them. And this is just an example of VAP cases from a US-based ICU. And you can see the variety of pathogens that can be isolated. And even we say that early VAP can be more susceptible than late cases. You can see some cases of MDR pathogen coming in the early 5 days. You heard this morning and afternoon about the importance of early appropriate therapy, and the data has been replicated from old and new data, all agreeing that the later you delay effective therapy, the worse is the outcome. So window one here is a time where you would implement an effective therapy for your patient. And your ideal diagnostic tool should be able to help you by identifying the pathogen and identifying any resistance markers it has, optimize your antimicrobial stewardship by obviously, giving the narrowest spectrum antibiotic if possible, and also not exhausting your resources. And on the top of that, clinically impactful, you want to see the impact on the patient outcome and, for example, other parameters like length of stay. Do we have such an ideal tool? I will leave this question for you to think about it and answer it inside yourself by the end of the presentation. What I can tell you that there are multiple cluster multi-center RCTs are ongoing at the moment to address this question and finding an optimized tool that can help ICUs. All diagnostic tools that we have in the market at the moment are not without limitations. The evidence is still limited, whether regarding the clinical utility, their impact on stewardship, on the clinical outcome, and also on cost effectiveness. They are considered an additional cost for the lab because none of the currently new assays can replace routine microbiology work. In general, they tend to be less quantitative in the final report, so even those assays that have, for example, semi-quantitative nature in lower respiratory tract samples, for example, they won't be as clear like culture to tell you about if this is likely to be pathogen or colonizer, or, for example, +4, +1 culture thing. It needs from you some infrastructure before considering having an assay, and more importantly, it needs an effective team work. So really an effective MDT team, adequate staffing, and you need a robust IT structure in order to be useful. We are expecting the next generation of rapid tools to be addressing these issues to have more adoption and more clinical impact on the patients. So what assays we have? Some of them are molecular, some of them are rapid, but phenotypic simple assays. Some of them can be performed on the samples, others can be performed on positive cultures. They can be placed in the lab or in the unit itself as a point of care. Some of them are targeting a particular pathogen if this is your main problem in your ICU, while others are syndromic. You can introduce them as such, or you can incorporate them within an effective antimicrobial stewardship program. And a very important artificial intelligence-based concept now is coming as a new tool in ICUs, which what we call predictive microbiology. And artificial intelligence has a wide applications in microbiology, right from specimen collection until handling complex genomics data. So trying to applying those on bloodstream infections, if you look at these, you can't find 3 pink triangles proposing the 3 different models where your laboratory will work to produce a final report for bacteremia. The one on the right is the one that is conventional on the top right that will take 3 to 4 days, 3 in the best, usually 4. And then you can cut 1 day or more from them if you introduce a rapid assay in the lab on a positive culture, like MALDI or Accelerate. And you can have an assay that is performed on the sample, and in that case, you will detect the pathogen and possibly some resistance markers within the first day. So again, this is the same, but you can see clearly here the effect on the time. So all the assays that are underlined here are US FDA cleared. You can have MALDI, for example, that is performing on a positive culture, or you can perform assays that are directly on the sample or flagging positive blood cultures. In our institution, we have MALDI, we have film array, we have evaluated accelerate pheno, and we are considering now the evaluation of T2 system. The first thing that comes to mind when you think about these things is the cost. And actually, some evidence suggests that the assays can be useful even in the absence of antimicrobial stewardship program, particularly certain assays. However, most of the rapid tools are best utilized when they are coupled with active intervention. And I will refer you to this model now that is shown. And as you see, for example, on the right lower part of the graph is your ideal assay, which will impact the final report, time coming to you, but with a low cost, and that is the MALDI, as per the pricing for the MALDI assay in that particular country, which may not necessarily reflect here in the GCC. There is also some debatable evidence that cost can be cut by introducing those new tools in the ICUs, and most of this saving is coming from bed days and the total hospital length of stay. However, we don't have local data to support that at the moment. I know some colleagues are evaluating this, but nothing came to publication. I will show you the two largest meta-analyses that evaluated the clinical impact now of rapid diagnostic for bloodstream infection. So that was about the cost, but about the clinical impact. The first meta-analysis evaluated the impact at 3 levels. Molecular assays alone without any intervention, molecular assays with active intervention, and rapid phenotypic test with intervention. And if we start by just having a rapid molecular test, bringing it without doing any additional work, most of the studies, there are few, this meta-analysis came 7 years back, most of the studies evaluating the time to initiate targeted therapy, not any clinical outcome. And you see most of them, they were in the favor of the rapid assays, apart from the last study by Fry, which can be partially explained by the high rate of blood culture contamination in that study. And that was also evident in the forest plot. So the second arm was molecular assays with additional direct communication from the lab to the ICU unit. And here you can see it more clearly that the rapid assay worked most of the time in the favor of having it. 2 studies only evaluated mortality, and you need to note that most of the study quality were defined as below good. The effect was magnified in one study, the Hale et al. Study, and you need to note that only 21 cases were included in this study. And this is the cumulative effect in forest plot. If we want to check the clinical utility of rapid phenotypic test in the lab with additional direct communication, because this is potentially a very cheap tool, your lab just will accelerate the result by doing a direct testing without a very additional cost. And there are only 2 studies which evaluated that. The quality is not the best, but both of the studies concluded that they have potential to have a better clinical output. The second meta-analysis is coming from the Cochrane collaboration, and it's more recent, published 2 years ago, 1.5 years ago, and it had more stringent inclusion and exclusion criteria. Only randomized clinical trials were included in this analysis. They focused mainly on the clinically meaningful outcomes, including mortality, length of stay, not the lab performance. So they were not evaluating the assay, rather they were evaluating the clinical impact of the assays. And the conclusion of the study that there was no evidence to support the use of the rapid diagnostic in bloodstream infection, neither in the initial analysis nor in the subgroup analysis, in terms of mortality, time to discharge, or even time to start appropriate antibiotic in these RCTs. And the definition of rapid was here 8 hours. So if any assay produced a result in 8 hours, that was considered as rapid. And the more important recommendation of this meta-analysis was that all our future work should address good outcome when you evaluate these assays, because unfortunately the literature is full of publication that examine the performance of these assays, but usually they evaluate the laboratory performance of the assay rather than the clinical impact. What about respiratory tract infections? So again, the same models. Your lab may work either on the routine diagnostic and produce your result in 3 days, sometimes more if it's mixed. And then you can cut that 1 day or more by having a MALDI in your lab, or you can have a rapid tool that's performed directly on the specimen. And it will help you not only to detect the pathogen, but also resistance markers potentially. So this is the list of all FDA-approved assays for a lower respiratory tract sample. So here I'm not talking about upper, because there is a much longer list for upper respiratory tract samples. So this is only for lower, focusing on ICUs. So you can see they have a variety of pathogen to cover. Only the film array and the Univero have resistance markers in them. And the turnaround is also variable, so it really depends on you. What do you want of the assay? If you are having a particular problem in detecting one particular organism, if you are failing to detecting some organism, if you are working with a high rate of ESBL, so you decide what do you want of the assay, and then based on that you are going to select the assay. And most of these assays are low complexity, and they can be placed in the ICU itself. Do they work for pneumonia, clinical impact? We don't have a dedicated meta-analysis for respiratory tract samples as of such, because the lower samples are only coming newly to this field. Most of the other respiratory infection assays are for the upper. But we have this combined meta-analysis that examine all type of infection, including lower respiratory tract, and potentially there is a good clinical impact of those assays on the clinical outcome. But as I said, we need more solid data to conclude that. One more concept to introduce in relation to a new tool for the diagnosis of a serious infection in the ICU is the use of predictive microbiology based on artificial intelligence. So we're familiar with predictive micro right from simple clinical scoring system, like for example the CPIS that is endorsed by the Infectious Diseases Society of America for diagnosis of VAP. Now, the predictive micro is becoming more advanced, and it's time for the lab to shift from routine traditional antibiogram into what we call syndromic antibiograms. WISCA is just an example, which stands for Weighted Incidence Syndromic Combination Antibiogram. Those antibiograms is a collaborative work between the lab and the ICU, so the lab cannot generate this antibiogram on its own. It needs really a huge input from the intensivist. And what you need here is to have antibiogram that's addressing all the microorganism causing, for example, VAB in this case, considering the local epidemiology, polymicrobial etiology, and also drug combination. And this is the final look of a WISCA in comparison to the routine antibiogram. It is done by an intelligent machine, so you're just going to instruct the machine. It's a calculator. You're going to first define which level of precision you want to be at, as you heard this afternoon nicely from Dr. Heil, depending on the severity of the patient, how severe is the illness, and also how much accuracy you want to be at, referring to the guidelines, anything between 80 to 95%. And if you go, for example, for the ALAHSA guideline, they would recommend 95 for cases of VAP. These are the questions that you are going to answer in that calculator, putting all the patient data, including the second column, microbiological data, which are more or less the same data that we use for CPIS score in simple scoring system, but here they will be integrated with other more complex patient clinical data. And here is just one evidence to show the impact of using those predictive microbiology tools. This study compared the correctedness, I would say, of appropriate therapy before and after using the tools. And you see the impact is mainly seen on gram-negative in that particular institution in the US. And of interest to me is that the uptake rate was really good. So 72%, that's 3/4 of the physicians were happy with the suggestion that was given by the intelligent tool. So this is a new concept, I think. So predictive microbiology now is being translated into what is called clinical heuristics. So we're back now to things that are maybe more primitive, but they work, and we just need to generate more evidence for that. And this is just an example how a WISCA will appear for an intensive care, and this from an institution in Canada. So to put all of that together, this is the proposed success model. I don't think that having, no matter a good assay is in the market, you might have an assay that is published under sensitivity of 99%, specificity of 100%, negative, what's the predictive value, the way you can define it, the way you like in the literature. But if you just take that assay and you just place it, whether in a unit or in a lab, it won't perform as you would wish. So really, the best way to handle a new tool, whichever the tool you will select, is to incorporate it into a highly effective stewardship program covering all aspects, both diagnostics and therapeutics, and having a good communication between all team members, and also trying to eliminate the human factors in anything that can work without a human. For example, giving codes in the LIS. So you just activate a sepsis code in your LIS, and the lab will know that this patient is coming with sepsis or possibly sepsis. Now, it should take another pathway inside the lab. And you can think about application not only in bloodstream infection, but or not only ICU infection, actually, potentially any infection. So my home message is here. Rapid diagnostics may not be useful in every single case, but I believe they can be very helpful in timely identification and of the organism, and also preliminary identification of its resistance profile. However, we still need to learn much more about those assays. We don't have that good quality evidence in the literature. We need to work to generate our local data, and also we need to read what is coming from those RCTs. The principles of prediction and predictive microbiology, I think this is a very simple, cheap tool that can be potentially introduced to ICUs. ICU is a small environment, although it has a lot of challenges, but I think this is the best place to apply an antibiogram if you would like to. And that prediction can take you to designing better empiric regimen that is personalized for every patient based on WISCA or other prediction tool. I hope that you don't think that we are in the lab just pressing a magic button. And thank you for your attention.
Thank you, Dr. Amani. I would like to invite all the speakers to the panelist discussion.
Any question from the audience? Dr. Tariq, the mic, please. The mic, please, to Dr. Tariq here.
With the novel beta-lactam antibiotic, are we seeing more neurotoxicity? I'm noticing this in ICU. I've seen it in cefiderocol, I don't know if the duration making those patients at higher risk to have neurotoxicity from prolonged beta-lactam. Have you seen this in your practice in ICU, Dr. Omrani?
That's a very interesting observation. I don't think I've noticed this. And I was thinking about the randomized trials of cefiderocol and also the real-world studies, which are a handful, and most of them included less than 15 patients. I don't recall them particularly mentioning neurotoxicity. Whether what you just proposed now, which is maybe that they've been exposed to lots of beta-lactams before eventually arriving at cafe-deracol is a factor, that's possible.
Could be.
Any more question? Dr.
Yes.
Hayal?
Thank you so much. Dr. Ali, do you have any experience or are you aware of any evidence behind, using bacteriophage for MDRO infections, especially the severe ones? I'm aware that there are some emerging evidence, but in your experience, do you think this is going to happen soon in our region, for example, or do you have any experience with that? Thank you.
That's a very interesting thought. No, I don't have any direct personal experience, and everything I know about bacteriophage therapies is what I read in the literature. And what I read in the literature leaves me with the impression that this is still largely investigational. I think even in the Western world, it's not something that you would see outside research as far as I could see. I'm not quite sure how, I'm not aware of any place where they're using it routinely as part of their treatment options. If you want me to look ahead and think, are we going to see it in the region? I'm old enough to remember lots of things that we were very excited about in the past 20 to 30 years, and then they turned out to be nothing. So I trained myself now not to get to be excited until it's there.
Yeah, fair enough. Yeah, thank you.
Dr. Hayal?
Malish, once again, Ali. We had this debate amongst ourselves for carbapenem-resistant Pseudomonas. Would you go with ceftolozane, tazobactam versus ceftazidime, avibactam? And it hasn't been resolved, I would say. So what is your preference personally?
Yeah, thank you. No, very quickly, there's nothing whatsoever to say that either of them is better. Ceftolozane was very successfully marketed as an anti-pseudomonal agent, but if you leave the marketing tricks aside, ceftolozane's main advantage over ceftazidime is its anti-pseudomonal efficacy because it evades certain efflux mechanisms. So it's a limitation because obviously it doesn't have activity against carbapenemases. But you can spin it and make it an advantage. The reality is that if an isolate is susceptible in vitro reliably to a beta-lactam agent, whether it's ceftazidime, avibactam, ceftolozane, tazobactam, or any of the others, then there's no real reason to expect that any of them would be more efficacious. If there were reasons to prefer them because of policy or because of cost, or that's possible, but not because of expected better benefit. If I have 30 seconds, I'll add something about imipenem-rilibactam, which is not widely available in our region. Now that's also a beta-lactam, but it has a very obvious advantage as an anti-pseudomonal agent, because the imipenem overcomes the AMP-C production in Pseudomonas. So you find that imipenem-rilibactam has a much broader activity against multi-resistant Pseudomonas than the other two, but not because of expected better efficacy if they're susceptible in vitro.
Because the question came as, should we delete one of them? Or delete?
Should it be only one of them in a formulary?
No, I mean, if we have both, should we keep both in the formulary?
I definitely think we should have everything we can get our hands on as a general rule, but specifically those two, yes, because there are sometimes occasions where, particularly in Pseudomonas, where a bug is susceptible to, say, ceftolozane, tazobactam, but not ceftazidime, avibactam. And in this setting like yours, where you obviously see highly complicated patients, many of them are critical. So I would think that if it was up to me, I want them all, and then find the right way to use them.
Dr. Zakaria.
Assalamu alaikum. So I have a question about AMC producers to Dr. Ali Al-Amrani. in the latest iteration by IDSA on the treatment of resistant gram-negative enterobacteriaceae, they mentioned that we should drop out the traditional teaching of spice organisms, and AMC is mainly found in Enterobacter cloacae and aerogens and Citrobacter cocceri. My question about Morganella, Serratia, Providentia, and Proteus, they said that the incidence is less than 5% in these types of organisms. That's, I think, according to their studies. Do we have data here about the other AMC producers other than Enterobacter? And do you deal with them as AMC producers in your practice, or you just treat Enterobacter as AMC or the other?
Yeah, thank you. I think the reason I'm getting all the questions is a reflection of the importance of gram-negatives in your practice. It's just like everyone said, we don't see a lot of MRSAs and so forth. The answer to your question is, we have better data on the risk of emergence of de-repressed AMC mutants with Enterobacter and what was renamed as Klebsiella aerogenes. It used to be Enterobacter aerogenes, and to a lesser extent with Serratia than we do with the others. And I think this is what they're referring to. It's the availability of risk assessment of what is the risk of emergence of de-repressed mutants if you were to use an inducer. In terms of practical prescribing, I would advise you to follow a phenotype. So if your lab reports a reliable phenotype, you can more or less use that. If you're able to convince your lab to routinely release cefoxitin and aztreonam and other third-generation cephalosporins, then you will be able also to do some interpretive reading if there wasn't someone out there to help you. I personally, and this is a personal choice, I don't use Biptazo for the species that you named. I don't use Biptazo for Serratia or Morganella, but I do for Proteus, but I don't use for those.
Thank you for the committee. Question for Dr. Ali. What about the use of aztreonam combination for CRE treatment? The use of aztreonam in combination for treatment of CREs.
Yeah, if you're treating an MBL producer, a metallo-beta-lactamase, then combining aztreonam with an inhibitor, what you want is avibactam, but you can't get it alone, so you have to give it with as ceftazidime avibactam. So this is what it is. MBLs, those class B metallo-beta-lactamases, are awesome, but they're not very good against cephalosporins. And they're also not able to hydrolyze aztreonam. And on the other hand, ESBLs are superb in hydrolyzing aztreonam and cephalosporins. Most MBL producers simultaneously produce ESBLs and other enzymes. So if you use avibactam as an inhibitor, it would inhibit those ESBLs, and then that would release aztreonam because it will not be affected by the metallo-beta-lactamase. That's the principle behind it. So it's specifically using avibactam with aztreonam. This was never shown in randomized trials, but there are many large clinical series, and I think most of us have decent anecdotal experience. Most of the experiences with Enterobacteriales. There have been some reports also of successful use in Stenotrophomonas. I haven't done that before. And I've never come across any data about its use in Pseudomonas, which is obviously a very different beast.
Yeah, I have a question for Dr. Amani. As mentioned by Dr. Ali, the traditional antibiogram doesn't reflect the reality. Maybe the susceptibility doesn't actually show what's happening. And VISCA, the predictional model, seems to answer that issue. I just wanted to know, is it already being applied in hospitals, or it's just being tried? Is it widely being applied across the hospitals? Because this is the first time I'm hearing this word, VISCA. Thank you.
Yeah, thank you for the question. Yeah, thank you for the question. So the VISCA has been there in the literature for now more than 7 years. It's morely applied in the North American hospitals, perhaps especially in Canada. There are very good models. Not all of the work has been published, but if you go and visit the local antibiogram data from the hospital themselves, leading institution, for big well-known universities in Canada, for example, and then you go to their local antibiogram, you will find all of these data. They will also cite some references for that, but if you look in the literature, I think we need more time to have more evidence on wide adoption. But if you think about the principle behind it, in your empirical therapy, you want to cover all the things that you just heard today in this conference event. You want to have your local epidemiology taken into consideration, patient factors, if there's an ongoing outbreak, possibility of polymicrobial infection, and what antibiotics are available in your formulary. And that's what WISCA will do for you. Whether it will be good or not, I think how robust it was also performed and which regression model it was performed. You need a statistician with you on board. And as I said, it needs huge ICU input in developing it. So the lab cannot do it alone.
Dr. Huda, just can you the mic here?
My question again to Dr. Amani. I want to know about in patients who are immune compromised. These panels, how will it help? It should help us with these because they are exposed to a variety of organisms, and the differential diagnosis can be, especially for respiratory tract infections.
Doctor, I tend to think maybe the opposite. I think those syndromic panels in general that are in the market, they are designed to answer the question, which is the main limitation of PCR that we know. PCR will answer only the question if you have a proposed answer in your head, because they have targets defined for each infection. Now for immunocompromised, it's an endless box. For example, if you're thinking about any type of infection, whether it's bacteremia, whether it's a synovial, whether anywhere in immunocompromised, you can have any opportunistic pathogen, any environmental, any flora, for example, can contribute to the infection part. While in those syndromic panels, there are only those that are well known to be in pathogenic status in that site. So thinking about, I think, an immunocompromised institution or think like that, we need to think more of genomic study. 16S as the least, at least 16S will help you to, 18S in case of fungi and 16S for bacteria, because in that case, for example, 16S will tell you that there is bacteria and then it will be sequenced and it will be identifying any bacteria. 18S, it will tell you, yes, there is a fungus and identify any fungus. And of course, what is even better than this is now we have the omics, which is like genomics study and bioinformatics, and يعني أضعف شيء واحد ممكن يعمله connecting ourselves to one of those leading institutions, bioinformatics and genomics-based center. I think also in Riyadh there are some centers that are doing good work on this at the research level. But if we can't connect the diagnostic to the research side for that, this is the answer for the immunocompromised. None of the syndromic panels will be inclusive even for 10 or 20% of the pathogens in immunocompromised, I think.
زكريا.
السلام عليكم. أنا عبد العزيز المؤمن ID consultant في الدمام. بس سؤالي لدكتور علي, is there any data for cevidical combination therapy compared to monotherapy? Like the study that you presented showed that it could be a bit inferior to standard of care, but was it used in combination therapy studies?
Yeah, thank you. A lot of people usually are interested in combinations. There are only observational studies that reported cafidaricol use in combination with other things. And from what I see, I don't see it really as offering any advantage. And I could say also in the same breath that there is no evidence generally to support routine combinations for most things when you're using a beta-lactam. So in cafidaricol's case specifically, I can remember off the top of my head 2 different observational studies, and they both did not show any particular advantage if used as combination.
I have a question to the panelists, and starting with Dr. Reem. Now, you talked about the retirement for the vancomycin, and now with the newer diagnostic tool that cut off a lot of time to get an initial information. So do we see in the horizon the retirement of the word empirical therapy?
Thank you very much for the question. Again, it's very challenging to answer as most of people are in between. They're claiming that there are more effective agents against MRSA rather than vancomycin. But again, when you see the practice, they're going back again and again and keeping vancomycin as their first choice. I think maybe because there are no studies yet that can convince them clearly that they can't stop using the vancomycin. And even for us, yani, as a practice, if we think of it, not only the use of vancomycin, when we came to decide our target for the patient, should we go for a trough or AUC? Even me, myself, when I was preparing my hospital protocols, what are the target of troughs? Most of the studies suggesting to limit it to less than to 15 because of the nephrotoxicity. But when you came and put it in the protocol, should you limit your patient with CNS infections or who's sick at the ICU to 15? Or if you limit it to 15, if he came with a level of 17, would you adjust the vancomycin? It's very difficult. From my side, still I don't have a clear answer, and I cannot clearly say no vancomycin for the patients.
I'm old generation who believes in vancomycin. So, but again, I'm a microbiologist who always like to recommend advice based on in vitro data. I mean, if you have an MIC which is borderline, for example, even if it's susceptible, but it's tend to be higher, and you have other alternatives in your formulary, this is one thing. Again, the duration of therapy needs to be also considered. I mean, considering all the other resistance profile. But it's just what Dr. Ali said. One would like to have all antibiotics in the formulary, and then you design your own ways in your antimicrobial stewardship committee where how they can be used. So maybe what is good for a patient, not necessarily the best for the other. But I don't think that vancomycin will be removed soon from the pharmacy.
Okay. Dr. Ali, about the, not only the vanco and the other for the drug-resistant gram-negative. Are we seeing a retirement of the term empirical therapy with the availability of the new diagnostic tools, since we have a new tools that get an initial information within hours?
Well, let's first vote for vancomycin. I agree with you. I think vancomycin may not be a great drug. It's certainly not perfect. But I don't think there's been anything convincing that it's something consistently better. And it's also a beast that we know. You could always check the serum level, and you can always adjust. You can always increase, decrease. You can give us continuous infusion. If a patient's renal function is rapidly changing, if they're on CRRT, it's something you can adapt to. But what exactly are you going to do if you're using daptomycin or telavancin or any of the others? We just don't know. Back to your question, well, I wish a time would come that we would really have those detailed diagnostics at a snap at the time of decision making. But this is really not, I mean, Dr. Amani didn't promise you that this is happening next week. She said these things are happening. I don't think it's going to happen during my lifetime. Maybe in a future time, but not in my lifetime. I think we will still do a lot of empiric decision making. Maybe the difference will be arriving at certainty sooner. So maybe in hours, or maybe a day rather than now, 3 days, 4 days, lots of negative culture sepsis, maybe.
I just want to add to what Dr. Ali said. Actually, some of the assays, even when you bring them to your lab and you evaluate them, during the evaluation time, they are just perfect. I mean, you are the one who is evaluating them, and they are perfect. But once you introduce them to the real life and seeing the patient, then you start to see all the limitations that you never heard about before. So I think there will be nothing to replace a clinical judgment.
Yeah. Okay, thank you. I thank the speaker for the excellent lectures, and back to the stage.
Thank you very much for this amazing session. I'd like to invite Dr. Zainab Al-Musa, Dr. Mustafa Saad for recognition of speaker and chairperson. Dr. Ali Al-Amrani.
colleagues, Dr. Badr Al-Mohini. It is my pleasure to present the first speakers, Professor of Medicine, Dr. Hail Al-Abdali. Dr. Hail is a Professor of Medicine at Al-Faisal University in Riyadh, and he's an infectious diseases consultant at King Faisal Specialist Hospital and Research Centers. Dr. Hail has subspecialty training in infectious diseases, was at the University of Texas Health Science Center at San Antonio in US, and he is the former director of the Central Branch of Saudi Society of Medical Microbiology and Infectious Diseases, and he has authors or co-authors over 65 peer-reviewed journal publications with several books chapters in the area of medical mycology and infection controls. He is also a reviewer of for several journals in the field of medicine and infectious diseases regionally and internationally. Dr. Hail, he is presenting the epidemiology of invasive fungal infections in ICU. Dr. Hail, floor is yours.
Assalamu alaikum. Good afternoon. Thank you very much for the nice introduction. I would like to thank the organizing committee for such a smart conference. I really liked the program, focusing on certain aspects, quite interesting, getting very good speakers. So thank you very much. I know it's getting late, and thank you. I think we had a good audience. And my task is to bear with me in about 20, 25 minutes to go over the epidemiology of invasive fungal infections in the ICU, as it's the focus of this conference. I'll try to have more of local data within the kingdom and also within the region. So to start with, if we look at infection is an imbalance of exposure to defense. And whenever the balance towards more of exposure or less defense, then infection is likely to happen. And fungal infections are not exception, of course. And the determinant would be either an inoculum size and a virulence. If the organism is not as virulent, probably you need a larger inoculum size. If it's virulent, probably you need just a little to cause infection. And with the host defenses, we know we do a lot of things to patients, and they acquire a lot of things that depress immunity, or a lot we don't know. We don't know why somebody get pneumonia and not somebody who's next to him. So there are things which are deep, still getting discovered day by day. In the ICU, this is the right setup or setting for infection, because immunity is likely to be affected, and inoculum and variance is likely to be there as well. So when we look at the history of fungal infections, for hundreds of years, fungal infections were not in the front line, and even in the past, recent medicine, in the past 150 years, still fungi were not in the front line. One reason is they were not as common. Actually, about 100 years or more, dealing with ringworms and athlete foot. That was the concern. And before 1940, there was interesting actually articles, I looked at them, and they were applying some poisons to get rid of a ringworm. And then when x-rays were discovered, I think 1902 or so, they were actually using it in some studies as a treatment. So you can imagine how desperate they were. Other reason, bacteria were causing a lot of problems, and there were no therapy, mortality is high and quite prevalent. So fungi were in the back. But then, from the 1940s onward, we start to be good at treating patients. We had two major breakthroughs in science, antibiotics and steroids. And these helped a lot of patients, actually saved millions of lives. But again, we have to have some expense. We started to see some thrush, some infections, and a little invasive infections tried to creep up. And as we had more advancement, now treating cancer with chemotherapy, and then end organ with transplant, and then a great boost to fungi, to our disadvantage, came with the AIDS pandemic, where fungus, many fungi has been in the front line, especially the Cryptococcus, dimorphic fungi, Candida, and to less degree Aspergillus as well. With that, there has been a huge advancement of critical care. We've been kind of, I wouldn't say aggressive, sophisticated in actually caring of patients in the intensive care, doing a lot of invasive procedures. And all of that, of course, we have to pay a price for it. And the price is to get organisms, which usually doesn't cause infection. We don't walk in a place or in a hospital with fungal infection. Typically, we get it within because it's opportunist. And then we started to see invasive fungal infections, and predominantly it's Candida and Aspergillus. And just again, putting it in a different shape, we get exposure, either external environment. Any one of us today will have at least 15 conidia of Aspergillus inhaled just from the environment. But our innate immune system takes care of it, no problem. In a patient who is immune suppressed with whatever, then these 15 conidia may actually get to the site and not get cleared up. Candida as well, it's a normal flora, and whenever we cross the barriers with a surgery or a line or something, then we may get Candida up. And we eliminate, of course, the competitors with the bacteria with our antibiotics, so it's just the right environment. And also, which is quite important, and I think now Candida auris has taught us this lesson, that as we care about MRSA or multi-drug resistant gram-negatives in terms of transmission, horizontal transmission in a unit, also Candida species. And in fact, many years ago, Candida parapsilosis in ICU has been a problem with horizontal spread. And nowadays, I think we know that actually we do spread Candida species in the unit, especially ICU. Of course, this is just the right environment for the right setting for Candida. And then, of course, depends on variance and volume we get, but we have a solid defense. We have blocks of defense, and whenever it's there, we're okay. But in the ICU, they're not always there. So what happens in the ICU? The patient in the ICU is hosted because of major problems. Either a patient with leukemia who's neutropenic, with sepsis, patient with complex surgery coming to the ICU, a patient with different autoimmune, bad lupus, for example. And then, so they are already at a disadvantage. Then we try to help them by mechanical ventilation, putting lines, giving more drugs, and then we end up with a patient who is very vulnerable for invasive fungal infection. And the epidemiology will be determined according to vulnerability of patients. And if you are in a hospital like mine, where we have transplant, hem-onc patients, complex surgeries, then you are likely to see more invasive fungal infections. If you are in a community hospital where you don't have much of that, you get those referred, then you are likely to see less fungal infections, invasive fungal infections. Okay, so going back to this, so what happens that make patients in the ICU vulnerable to invasive fungal infections? And actually, our physical barriers are compromised, typically, with what we do. If it's a mucositis from a chemotherapy, if it's a structural anatomical problems in the lung, where Aspergillus likes this environment. If it's a line, if it's a TPN, then this is just right for fungus and candida in particular to go in. And physiological barriers, actually there are millions of fungi and we are protected from millions of fungi while plants, for example, are not as protected, amphibians are not as protected, reptiles are not as protected because of what we call it hemiothermy and our temperature. Then also alkaline medium is not good for fungi, and we have 7.4, which is little alkaline, so it's really good. In the ICU, these get altered. We have metabolic issues with hyperglycemia, with acidosis, with catabolic state, and then also we get those patients more vulnerable. Then we have our innate immunity, which seems to be, for fungi, is a major defense mechanism, especially phagocytosis. So typically also in the ICU, they get affected, both the macrophages as well as the PMNs. So just one more, and then the fungus is there to cause the infection, and that's the sophisticated adaptive immunity, which also get affected by factors within the host in the ICU. So with that, the patients are ready to get fungal infection, invasive fungal infection, unfortunately. One important thing in the environment of the ICU, those patients need intensive care. So a lot of people coming in and out, they need help from paramedics, from a nurse, from a physician. If you are in a teaching hospital, maybe even the students. And for infection control, of course, we don't like that. We like a limited number of exposure because spreading the bugs between patients is likely to happen. So with that environment, it's just the right setting for invasive fungal infection. And in the ICU, you're mainly concerned with candida, primarily, and maybe aspergillus, depends whom you are hosting in your ICU. And these are the basically defects that can happen favoring candida versus aspergillus, where macrophages, both, but more towards aspergillus, PMNs, kind of both. The mucosal defect, more of candida, T-cell defect, more of aspergillus, complements towards candida immunoglobulins, and antibacterials. Basically, you know, vacuum will not stay as vacuum. If you eradicate a component like bacteria, it will be filled by something. And here the fungi will just fill in. If you eliminate certain fungi, like say, I'm giving mold active agent against aspergillus, then in some centers, in cancer centers where they give that regularly, they start to see resistant molds, fusarium, scudosporium, mucor. So this vacuum is not going to stay. It's gonna be filled. And we have to be, again, as mentioned earlier today, to be judicious in how to deal with patients and management of patients. Okay, looking at data on the emergence of fungal infections in the ICU. This is from France, but has been replicated in other studies. And as you can see, for Candida and Aspergillus, in yellow or orange and green, there has been a surge over the years. And maybe a little in mucor. It's very small, but just a little increase in orange. And then when they went back 6 years afterwards, still it was getting even worse. So you can see here in 2016, you can see, well, it's the numbers turned to Hindi from Arabic. Maybe it's the computer then. So changed, still you have this invasive Candida and aspergillosis on this surge. While mucor may be a little higher, while crypto we seem to have less, and maybe the reason of our success in the AIDS pandemic, in treatment as well as in prevention. Okay, here putting several studies looking at Candida as a bloodstream infection and the percentage of Candida bloodstream infection in different centers in the world. I had a few global, like the ones in dark blue, and probably the main one is the one by Mike Fowler in Iowa. That's a Sentry surveillance, which is huge, more than 400 centers around the world. So you have it at 3.1%. But again, you have a center which is maybe a community hospital, another center which is a transplant or an oncology center, so you get it more. And then across all centers, according to what type of patients you're hosting, then you see. In our center, the green bar there, we are close to 11% actually of our isolates, plus stream isolates are Candida. So that's quite remarkable. Okay, seeing what kind of Candida and what happened over the years. Okay, we had albicans for years, and we were kind of happy with albicans because it is typically sensitive to our agents, the azoles, and of course, nowadays the echinocandins. But again, over the years, and if you see the years down, if you look at the US, three studies, 99, 24, and 12, you can see the glabrata has moved in gray, has moved from 12% to 29%. Parapsilosis remained more or less the same. But you see differences. Actually, in Latin America, still tropicalis parapsilosis seems to be still a dominant, although glabrata is creeping up. In East Asia, also more or less the same. When you go to Europe and United States, and I'll show you something regional, then glabrata actually is becoming the dominant non-albicans. Okay, this is looking at studies done here in the kingdom. I selected those with a relatively large number, about 100 or so. And you can see the percentage of Candida albicans with the years. I mean, these are done at different years. You can see we're moving down from albicans to non-albicans down to 35 or so % in recent studies. More or less the same is shown in Qatar, Kuwait, and Lebanon as well. This is from our hospital. We looked at our candidemia throughout the years from 1990, and we had them more like every 10 years or so. And you can see here, we were happy with the albicans at around 50%, and very little of glabrata then. And you can see here, 2012, glabrata is at 23%, quite impressive. And then more recently, we had maybe a little lesser here in glabrata, but again, we included all sterile body sites, not only candidemia. And also we started to see more resistant Candida species like Dubliniensis and Oris. So still, it's more the same trend, basically. And this is a review done by Dr. Kmaid and Dr. Kanj from Lebanon, looking at all studies and looking at the Candida species. And more or less, except for Tunisia and Algeria, where tropicalis seems to be a dominant one, then you see the glabrata, albicans, glabrata, parapsilosis are the dominant ones here in the Gulf. Mortality, throughout the years, I mean, you can see really, this is crude mortality, not very good. So we're not doing really good in terms of survival benefit, even with the different drugs we're using, interesting enough, at least from our local data, but there are other studies showing some benefit of the echinocandins over the others. Okay, then we got unwelcome guest, or intruder, I would say, and take over the house, just stayed. This is 2012, and we hardly had auras in very few countries, Japan, Pakistan, very, very few cases, Venezuela. And now we have it all over. And actually they stopped actually tracking countries. Now every country is tracking its own because it's a huge problem. And this is a data I think my friends at Ministry of Health, they just shared it last week with me. This is this year, last year I would say, data. This is on outbreaks in Ministry of Health hospitals last year, and looking at organisms, and see how Candida auris is taking over. We have 146 outbreaks related to Candida auris with 345 isolates. Then actually, Klebsiella, Acinetobacter, Pseudomonas, and whatever is coming after Candida auris. This is quite remarkable. And where it's happening, is it in one hospital, 2 hospitals, 3 hospitals? No, it's all over. And this is from the isolates from the regions. And you can see, of course, Riyadh is a large healthcare city. So you had it leading, and then Jeddah, and then, but it's all over. Oris is all over. And again, you get those patients with the Oris transferred from a hospital to another hospital for care, and then you get Oris moved around. So it's a problem. As you know, Candida auris is a multi-drug resistant, very difficult to eradicate from patients, from the environment, so it's really a big deal. Okay, this is our susceptibility data, our hospital for a few of the common Candida species throughout the years. And you can see from about 2007 or so, maybe 8, we start to see caspofungin resistant in Candida albicans. And for a good reason. We almost stopped using fluconazole. We are just hammering with anidulafungin and caspofungin. These are the ones at our hospital. And we start to see albicans actually, you know, coming a little down with the caspofungin in orange. When you look at tropicalis, we had a problem with voriconazole and fluconazole. Echinocandins remained, we have resistance, but remained okay in tropicalis. Parapsilosis, this is a fungus I'm disappointed with. I remember when I was saying, I'll give fluconazole to any parapsilosis and I'll be fine. It was usually a fluconazole fungus. Now see the fluconazole, it's really coming down to 35%. This is susceptibility, by the way. This is really bad. The glabrata, of course, azoles, you cannot rely on in vitro, so we remove them altogether. And we have also, as you see, we have a dip even in caspofungin. And if you lose caspofungin for glabrata, maybe you can give amphotericin, but it's really not very good. Okay. Now looking at aspergillus. And aspergillus, we used to say, okay, it's hematology, oncology, neutropenia, bone marrow transplant, solid organ transplant. Now, no, it's not only that. It's actually patient with COPD, patients with viral pneumonitis, influenza, and now Kappa, the COVID-associated pulmonary aspergillosis. And we have nowadays acquired resistance in Aspergillus fumigatus. So it's really an issue. In our region, flavus is by far #1, and it's relatively higher MICs for antifungals than the fumigatus, so it may be tougher. Here looking at this, these are interesting studies on aspergillosis in the ICU. Some are autopsy in the gray, and some are non-autopsy. And you can see it's quite significant. And these are not the typical hematology oncology. And actually 50% of them were COPD. As I said earlier, aspergillus likes this structure abnormalities, the COPDers, the bronchiectatic, the cavities, and the sittles, because we inhale it, the sittles there. And if the environment is good, it shows up. And in the ICU, the environment is good for them. So, and we give steroids, of course, it's common for COPDers. And again, if you have to serve aspergillus on a dinner table, it will like steroids. She will love steroids. Just give aspergillus steroids, it will prevail. Okay, again with the 2009 pandemic of H1N1, people realized that we are getting aspergillosis actually cases within those patients. And again, structure abnormality, but also interesting enough, there was a problem with downstream signaling and activation of effector immune cells. So it's actually also deep immune defects. And now it's actually quite common. So if you have a patient and you diagnose influenza causing the respiratory failure on a ventilator, aspergillus to look at. If you see here, many of the patients, 128, many of them, they have other predisposing factors for aspergillosis, but 21% they were healthy, nothing. So still you have to think of aspergillus in such patients. Kappa, I mean, this is autopsy studies, multiple autopsy studies, but they collected about 600, over 600. And actually in those autopsies, this is proven aspergillosis, 2% were having Aspergillus, those who died of COVID in the ICU. And 2% maybe not big, but with a pandemic, numerically, this is huge. So also Aspergillus. Again, just to tell you that we see flavus. Yeah, we've seen some fumigatus, but flavus. And Turius is naturally resistant to amphotericin, so also we see that. Mucormycosis, we see it infrequently, but again, if somebody is with bad mucor, he will go to the ICU. So you'll see a mucor over there, or he may turn with mucor in the ICU. And the typical predisposing factors, either trauma or diabetes or hematology oncology. And this is our local data from the military hospital and from our hospital. And because of the different population, you can see different underlying condition. See on the right is the military hospital where trauma, because it's military, you know, military exercises and war zone. Then diabetes, then some cancer transplant. When you go to King Faisal, and mortality 27.8%. When you come to King Faisal Hospital, then it's hematology oncology, organ transplant, and mortality obviously will be higher. So that's, but again, in ICU, you may see mucor, which is difficult to deal with. Okay, so a COVID patient, I'll end up, again, you have a slide timer as well, so only 3 slides left. So again, COVID patient, like I mentioned earlier, we have the CVC, the antibiotic, but also we give dexamethasone, which is kind of standard of care now. Tocilizumab, there's controversy, does it predispose, doesn't, there's controversy about it. And of course, the viral pneumonitis and what I have mentioned with COVID. And then we end up with candidemia, aspergillosis, and for some who are in India, where already they have they are the rank #1 mucormycosis country. Then with the COVID, the steroids, they surged into thousands of mucormycosis. Looking at multiple cohorts of patients with COVID in the ICU, looking at how percentage of candidiasis, it's really up to about 2% or so. And it's mainly because of what we do to the patient in the ICU, lines, antibiotics, etc. For aspergillosis, here it's more. It can reach up to 9% or so. And as you see, a lot of them, they get corticosteroids and they're immune suppressed, which is just the right setup for the setting for aspergillus. I think that's the last slide. Thank you very much for your attention.
Thank you, Prof. Hail, for the nice and comprehensive lecture as well as usual. Next session will be about the advances of diagnosis and management of bloodstream candida infection. It will be presented by my dear colleague, Dr. Yamam Al-Jishi. She is a well-known figure in infectious disease in the Eastern Province. She is an infectious disease consultant working in King Fahd Specialist Hospital, Dammam, and she is the head of, or the program director of the infectious disease fellowship program there, and the chairperson in the antimicrobial stewardship program. Dr. Yamama, the floor is yours.
Assalamu alaikum. Thank you, Dr. Badr, for the introduction. And thank you for having me today to speak about invasive candidiasis or candida bloodstream infection in the ICU. The main outline of my presentation is to talk about the risk factor assessment for candidemia in ICU, summarize practical things related to the fungal diagnostic in ICU patients for candidemia, and outline optimal management approach for candidemia in the ICU. So I think Dr. Hail Abdali make my work is easier when he elaborate about the current advances in the epidemiology of candida in our area. We know that there are 15 candida species that can cause a human disease. Of them are 5 that are the most important candida, which is albicans, glabrata, tropicalis, parabacillosis, and cruzii, in addition to the emerging pathogen, which is the Candida auris. When we talk about candidemia, it's a part of a spectrum of invasive candidiasis, which include candidemia with deep-seated infection or without deep-seated infection in the patients. We know also that Candida species infection rank in the top 3 or 4th hospital-acquired infections of bloodstream hospital-acquired infection, in addition to Staph aureus and coagulase-negative Staph and Enterococcus. And the reported mortality of candidemia in the ICU can range between 40 to 50% in those patients. What we know from the literature that our body is about 50 to 70% colonized with candida, so it's part of the commensal organism available in our body. And as Dr. Hayel mentioned, with the advance in the treatment and with the advance with the surgery that we are encountering currently, we have a lot of invasive infection with our commensal pathogen, and this is basically start when there is any breach to the mucosal surfaces, because the candida mainly are in the GI tract, where it can invade the abdominal cavity, or it can disseminate in the blood and can cause candidemia. In some circumstances, however, it can be just colonized without causing an infection, but another time when there is any immune suppressive status, when those patient undergoes chemotherapy that affect the mucosa of the GI system, then it can translocate and cause bloodstream infections. Multiple risk factors highlighted for patients in the ICU, and multiple studies tried to look at predictors for invasive fungal infection in patients in ICU. The majority of them, or highly ranked risk factors, were broad spectrum antimicrobial and the length of stay in the ICU, in addition to the presence of central catheter, total parenteral nutrition, mechanical ventilation, colonization before the infection, and surgical procedure or specific condition, especially things related to severe necrotizing pancreatitis or patients who have perforation in the GI system. So there are multiple studies looked at what are the predictive models that can help us, can be simple and can help the physician predict the risk of invasive candidiasis or candidemia in the ICU. Most of these predictive are simple and mainly based on clinical data related to the patients. Some of them like Candida score or Candida colonization index or Ostrowski score. All these scores try to look if we can predict the infection. The sensitivity varies, and the specificity not only based on what parameters they use, but even the prevalence and the incidence of the invasive candidiasis or candidemia in the patient population, it's vary. So it's very difficult to extrapolate something solid to use in your ICU, but you can apply it to your ICU and come with something more predictable for what you have. What they all agree, however, is the negative predictive value. So all these scores have a high negative predictive value of more than 90 or 95%, which can help you possibly rule out or at least put it in your lower in the differential of those patients, whether or not they have candidemia. The other part is about the Candida diagnostic. So when it comes to the diagnostic, we know that we have the traditional culture-based method and the new advances in non-culture-based method. Our challenge with the Candida diagnosis in candidemia is that the sensitivity of the blood culture is low, is somewhere around 50 to 60% of those patients who have a real candidemia. So when it comes to the advantage of the blood culture, we know that it's the standard of care. We know it can provide us with the species identification, and we know it can provide us with the sensitivity. However, the challenge is the sensitivity, that it's low, and even in the reports that or studies that looked at the blood culture positivity, they saw that when you come to those who have positive blood culture, the number of the colony can be as low as 1 colony per ml. The reason for the low sensitivity is the low level of the candidemia, early clearance of the circulation from the candida, sometimes intermittent candidemia, and in the cases of deep-seated candidiasis. Another challenging in the blood culture is the turnaround time. So you will need 24 to 48 hours until you have a growth, and then another 48 to 72 hours until you have sensitivity. Malditov came in the picture later on. It's still based on positive blood culture. However, its advantage is that it can provide rapid identifications within hours. It have a potential for resistant pattern identification. And the only disadvantage when it comes to the time is that it rely on positive blood culture. Non-culture based, there are several biomarkers that are available. Of them, the antigen antibody or anti-Menan and Menan antigen, which is used on the serum, and those antigen or serology tests are helpful in terms that they can be positive even before the blood culture by 6 to 7 days. However, they are affected by the colonization of those patients, so it can give, it can be not as specific as it needed, and the availability of those tests are still not broad. Beta-D-glucan is another marker which is basically address the fungal cell wall of the candida, and again it can be done on the serum. The advantage of it that it is a pan-fungal marker, so it have a good sensitivity. However, and you can use it as adjunctive marker with the blood culture. However, there are a lot of uncertainties about the appropriate cutoff, whether to use 80 or even more, and there are poor sensitivity, specificity, sorry, and false positivity. PCR is very specific, very sensitive, can be done on the blood, rapid test, can provide speciation, can be a marker for drug resistant. However, again, there is no standardization, it's more expensive, and it might not detect all the species, and still need a lot of validation. T2 Candida is another non-culture based. It's rapid. It can be put in the ICU. It can provide a result within 1 hour. It can be done directly from the blood, and it has very high specificity. However, its limitation is the sensitivity varies between patient population, and it detects only the 5 most common fungi or candida that cause the most common candida causing candidemia. So it can miss others. When it comes to overall sensitivity, specificity, and positive and negative predictive value, again, what we can see that all these tests have a very high negative predictive value that can help you to rule out the infection. However, when it comes to sensitivity, they are very much vary between patient population, ICU patient, and what type of ICU, and what type of, and what's the rate or the incidence of invasive fungal infection and candidemia in the ICUs they are performed in. However, there is another use for this marker, not only for diagnostic, however, we can use it for stewardship and to decide when to discontinue the antimicrobial therapy on those patients. And there are several studies that try to incorporate these non-culture based markers with the blood culture for discontinuation and ruling out fungemia or candidemia. One of the common of them is looking at the early discontinuation of empirical antifungal therapy in the ICU, and here they used more than 100 patients, and they randomized those patients to those that they received the standard of care assessment and the treatment, and those who have tested for blood culture for the candida, and they used galactomannan with them at the same time, at the time of the randomization and at time of 4th day. And what they found that the rate of the early discontinuation based on this biomarker was very high in the intervention group, around 54% versus 2% on those patients who are on a standard workup. And this did not affect subsequent proven or probable invasive candidiasis, mechanical ventilation-free days, ICU length of stay, cost, or patient mortality. So it was found that it can be a potential as a safe approach for early discontinuation of antifungal. Another important thing when it comes for the treatment of candidemia, that we need to be timely. That's why we look for rapid diagnostic, and we need appropriate selection. And this is, again, because of the variety of the sensitivity of the candida to different fungal classes, whether this is de novo resistance or it is an acquired resistance. And as you can see here, knowing what candida we are dealing with can affect our selection for the antibiotic. We know that some of them are resistant, some of them depend on the MIC for specific agent that can be used for. So as per the guideline, and the recommendation is that susceptibility test should be done for azole on all bloodstream infection, for all the clinically relevant candida isolate, and echinocandin susceptibility should be done for any patient who have a prior echinocandin treatment, and for Candida parabacillosis, and this is strong recommendation. Another reason is that we know that the drug-resistant candida is a threat level serious in the CDC, and we are now having the Candida auris, which is labeled as a threat level urgent, and because of multiple resistance in the Candida auris, and this is sometimes one of the trigger for the physician to look at what Candida, whether this is Candida auris or not, is the type of the resistant that they have during testing. So antifungal resistant is defined as the ability to grow at antifungal drug concentration that can arrest the growth or kill most of the isolate of that species. This could be intrinsic resistant, like we see with the Candida kraussei for the azole. It could be related to the biofilm formation capability of the Candida species. It can be acquired whether through tolerance or resistance because of the change in our patients' microbiota and because of the change in the environment and the agriculture. And it could be sometimes a clinical resistance when there are issues with the drug level at the site of the infection. So how we can optimize the management of candidemia in the ICU? One of the major questions now or later or early or once we have a diagnosis, and there were several approaches to address candida in the ICU. Prophylaxis was one of the strategies that was looked for, whether we use universal prophylaxis on those patients. However, it didn't prove any mortality benefits, and actually it's a concern for resistance, and it's only approved in high-risk population like hematological malignancy patients. Other than this, it didn't show that have any impact on mortality, even if there was some impact on the invasive candidiasis infection in those patient population. Preemptive is defined whenever you have a patient with a high risk for invasive fungal infection with a positive biomarker like beta-D-glucan. And it's, again, it didn't show strong evidence, but it's one of the approaches that you can use when you have a high rate of invasive candidiasis in your ICU. The criteria for initiating the preemptive therapy in many studies were not clear. There were, again, a concern about cost effectiveness of the strategies and the emergence of antifungal resistance in those populations, and still coming with a decision model is to be validated. Empirical antifungal, which is basically rely on clinical suspicion in patients with a high risk factor, and mainly in most of the study persistence of sign of infection or fever in the presence of broad spectrum antibiotics whether or not there are positive markers. Again, it did show that you can have invasive candidiasis confirmed in 20% of those patients who were started on empirical therapy, but again, it failed to prove a real efficacy and effect on patient mortality. So it's still something to look at and validate. Targeted therapy is whenever you have a culture-proven infection, and when it comes, so what about the non-pharmacological management for candidemia? One of highly ranked intervention for non-culture-based, non-pharmacological approach is infectious disease consultation, and actually it showed that it reduced the overall mortality to up to 28% with the ID consultation compared to around 50% without ID consultation. And basically because the ID consultation enhance the compliance of the assessing team in doing all the parameters required by the guideline, like follow-up culture, ophthalmology referral, performing appropriate echocardiogram, central line removal in a timely fashion. Other non-pharmacological management for candidemia, central line removal, and this is have a quality of a grade A, having the echocardiogram to rule out infective endocarditis, as we mentioned earlier. And one of the important and high quality intervention is having candida bundle, and this is again enhance the compliance of the treating team with the guideline recommendation for management of the candidemia and antifungal stewardship in the institution where there is a high risk population for invasive candidiasis. Persistent candidemia is again the persistence of positive blood culture for more than 7 days. Still, the importance of persistent candidemia is a controversy whether it is really affect the patient's outcome or not. It is found to be associated with the retention of central venous catheter, presence of metastatic foci, ineffective empirical therapy, and early source control was found to be protective when it comes to the persistent candidemia. And one of the important things with the persistent candidemia that was found is that it can help you predict Candida auris. But still, whether it have a real impact on the mortality of those patients or not is still a question. In a studies that looks at the persistent candidemia, where is an effective infection or antimicrobial stewardship that comply with the other management guidelines for candidemia, what they found that the main effects for the persistent candidemia, it triggered the primary team to look for unspecific site for infection that was not looked at the beginning of the assessment of those patients. So overall, when we look at how we can optimize the management, source control is really important in treating those patients. Early initiation of the treatment with early effective systemic therapy is very important, and appropriate duration that guided by the follow-up culture and the candidemia complexity is very important. Still, when there is a candidemia, the guideline would recommend echinocandine as a primary agent until we have a further identification. And there are no differences between the echinocandine classes. And why echinocandine? Because they show the mortality benefits compared to azole. There are better clinical and microbiological improvement on those patients compared with azole therapy. Whenever, however, empirical antifungal therapy is started and then Candida was not diagnosed and the patient is clinically improving, it's recommended to switch to fluconazole for shorter duration and then just discontinue the therapy. New azole and new candine, they did not reach non-inferiority compared to echinocandine. So echinocandine, they are still the usual echinocandine whether caspofungin or micafungin or anidulafungin are the top for the management of candidemia. Therapeutic drug monitor is something to be mindful for it. I know we don't do it for echinocandin, and we don't use azole a lot in the ICU. However, if we will use azole class, is something to think of. So take-home message from what I looked for is that having risk prediction model can assess us and identify and treat patients who are at a high risk for invasive candidiasis and directly reduce the mortality rate associated with the infection. However, we need to customize it to our ICU population, incorporating conventional with the non-culture-based technology can be helpful, and a good diagnostic strategy for invasive candidiasis with the best practice strategy, and ICD consultation and antifungal stewardship activity should be an essential part of candidemia management. Thank you.
Thanks, Dr. Jumana. It is my pleasure to introduce the next speakers, Dr. Muhammad Abdullah, adult infectious disease consultant in AL-AHSA Specialist Hospital. Dr. Muhammad obtained his bachelor's of medicine and surgery from Jordan University of Science and Technology, and he finished his Saudi board in internal medicine and Saudi infectious disease fellowship at King Abdulaziz Medical City, and also he is completing his fellowship in transplant infectious diseases from University of Toronto in Canada, and he is a member of many scientific societies like ABIC, IDSA, and ESMID, and American Society of Transplantations. Dr. Muhammad is going to presenting invasive mold infection in ICUs of host and diagnostic consideration. The floor is yours, Dr. Muhammad.
Thank you. Good afternoon, everybody. I hope everybody is awake. So it will be only a few slides about this interesting topic. So we'll talk about invasive mold infection in the ICU. What about the best diagnostic tool? So is invasive mold infection a problem in the intensive care unit? Who is at risk of developing invasive mold infection in the ICU? Are the available diagnostic tools applicable for patients in the ICU when we compare it with immunocompromised patients? So in general, as we know that fungi morphology can be classified into yeast and mold, and when we talk about mold, we talk about actually the most common molds is Aspergillosis species, then followed by mucormycosis, and there is some others. So as Dr. Hail mentioned in the previous data locally and internationally, that Candida is the most common invasive fungal infection upon ICU patient, although around 20% will be related to other molds infection, mainly Aspergillus, and rarely related to other molds, except in the last 2 years where mucormycosis start to be raised in some area of the world related to the COVID pandemic. So when we talk about Aspergillus today, we will talk mainly about invasive aspergillosis, and we will talk specifically about invasive pulmonary aspergillosis to be more concentrated about the diagnostic tool and what the challenges that the intensivist might have in the ICU. Classically, when we talk about invasive aspergillosis diagnosis, we should talk always about integration between the clinical host factors and radiological finding on top of that with adjuvant mycological diagnosis. So why it's difficult to diagnose ICU patient with invasive aspergillosis? And this was resulted in the previous data that associated with delay in the diagnosis and to raise on the mortality to around 50 to 80%. These 4 important pillars could be contributed to the failure of diagnosis of invasive aspergillosis in the intensive care unit. The first is that the discrimination between colonization and infection remains always a challenge for the intensivist and the ID. characteristic radiological signs which are usually present in the non-neutropenic patient might be absent when we talk about ICU patient. So if you institution perform examination routinely for autopsies, which may be the only way of diagnosis of aspergillosis in some cases, so post-mortem diagnosis. Again, the diagnostic utility of microbiology that usually validated for transplant, hematology malignancy might be not validated yet for ICU patients. This makes the diagnosis always a challenge. So when we talk about invasive aspergillosis diagnosis in the intensive care units, we are talking about many guidelines that started with the previous expert guidelines related to the European organization and mycosis group, plus a revised guidelines of the same mycosis group in 2019. There is recently guidelines in 2019 between the American Thoracic Society, and there is some expert opinion, and many algorithms was suggested, especially after the COVID pandemic, how to diagnose what we called COVID-associated pulmonary aspergillosis. So the evolution of the diagnosis and the criteria have been changed, or at least over the last 15 years, to elaborate more of non-hematology classical presentation of invasive aspergillosis and try to make it more applicable to other type of patients, especially critical care patients. So when we talk about risk factor, for example, when we talk about the classical risk factor that well known before for a patient with hematology malignancy and the stem cell transplantation are neutropenia more than 10 days, hematology malignancy, especially acute myeloid leukemia, allogeneic stem cell transplantation, especially those with graft versus host disease, solid organ transplantation per se, lung transplant, prolonged use of a steroid, which is defined specifically in that guidelines more than 0.3 milligram per kg for more than 3 weeks. Using other immunosuppressive therapy like T-cell immunosuppressive and B-cell suppressive therapy and inherited or primary immunodeficiency. Now, recently, after the COVID pandemic and the emerging classical cases or non-classical presentation of invasive aspergillosis in other type of patient, there are other considered risk factor need to be always keep in mind, and it shows that associated even with higher mortality despite from hematology malignancy and non-neutropenic patient. Those risk factor was in the literature mentioned intubated patient with influenza or COVID-19, COPD patient, cirrhotic patient, prolonged ICU stay, patient with diabetes, renal failure, hemodialysis, malnourished or alcoholic patient. Now when we talk about the clinical and radiological criteria, very important concept to know that in a neutropenic patient, they usually have angioinvasive aspergillosis. But when we talk about other critical patient or non-neutropenic patient, they tend to have more tissue invasive. And this has implication in the presentation clinically and also about the diagnosis when we talk about some mycological factor or mycological tools that we use, like the galactomannan or fungal cell wall marker that can be more common to be positive and in angioinvasive form. I mean in neutropenic form. So you don't expect it to be, for example, in a patient who are non-neutropenic because it's less angioinvasive. So the classical criteria for, this is why in a clinical presentation of a neutropenic patient, think of it like pulmonary embolism presentation, pleuritic chest pain, hemoptysis that can be massive, while in a patient who are non-neutropenic, they can present with non-specific manifestation or simply deterioration for ICU patient or failure to weaning from ventilator. This is very important to know in the pathogenesis of the disease when we talk about the type and the host of the presentation. The other things, the radiological data is very important, and when we talk about radiological data in aspergillus, we mean talking about more specific, more sensitive CT finding rather than simple chest X-ray. So these are the classical presentation in hematology and in neutropenic patient, the dense well circumscribed lesion, what we call the hollow sign, which is a nodule with a ground glass opacity around it, a crescentic sign, and cavity, and which shapes segmental or lobar consultation depend on the time of a neutropenic recovery. You might find one of those lesions in a classical patient. While when we talk about non-classical patients, like non-hematology malignancy or non-neutropenic patient, you might fail to have this presentation. You might have only bronchopneumonia, non-specific consultation, and the form that we see in COVID patient, they don't have a specific criteria relatively like in a patient who present with neutropenia. So this is an example of hollow sign in a patient with neutropenia, would tend to have invasive aspergillosis diagnosis later on. So it's very important to know that in phase of aspergillosis diagnosis or definitive diagnosis need a proven mycological finding in histopathology. So either you have histopathological or cytohistopathology diagnosis and microscopy examination of the aspergillus species in the specimen by taking biopsy from the tissue which was affected. Recovery of aspergillus from the culture of a specimen which again taken by a sterile procedure from a normally sterile and clinically radiological setting that's suggestive of the disease. And newly this criteria was added to the diagnosis of by molecular test and doing DNA or PCR amplification and sequencing for the molds, again in formalin fixed paramine embedded tissue. So this is a photograph of lung tissue biopsy for a patient who was diagnosed to have aspergillus. You can see the classical hive of aspergillus is acute angular at 45 angle, and it is usually septated to differentiate from other molds like mucormycosis, which we will see in the next few slides, usually tend to be wide angle and usually not septated. So other mycological findings apart from histopathology that might suggest the diagnosis in the setting of a clinical and radiological presentation as the microscopic detection of fungal elements in the sputum, lavage, or bronchial brush or aspirate that indicate mold with aspergillus growing in the culture. Again, presence of galactomannan, we will see in the next few slides what is galactomannan, that detected in the plasma serum or the bronchoalveolar lavage on an sterile fluid. The aspergillus 2 or more positive PCR, plasma, and serum considered nowadays as one of the diagnostic criteria that can be utilized in the setting of the risk factor and abnormal radiology in the CT scan. So this is microscopy that was taken where the fungal stains show that the conidio-4 for the aspergillus form, which is, if it is present, it can be pathognomonic with the high-risk patient, and it is the form that used for reproduction of the fungus. So galactomannan that we talk about at one of the mycological criteria is polysaccharides antigen that exists primarily in the cell wall of the aspergillus species. The most sensitivity of galactomannan when it's taken from the bronchoalveolar lavage by bronchoscopy sample. The most important or the most common cutoff point is more than 0.5 optic index. The sensitivity carries 79% with a specificity of 84%. Now it's very important to know that in the serum, the sensitivity will be lower in non-neutropenic patient and can reach only 50% for the reason that we have mentioned, that in a patient who are non-neutropenic, you expect less angio-invasive form of the disease. Very important for physician, ID, and intensivist to know the false positive causes of fungal antigen. Like previously, some antibiotics that beta-lactam antibiotic with claviculinic acid or beta-lactamase inhibitor was associated with false positive test galactomannan. Before 2010, piperacillin tazobactam was considered to be one of the cause of false positive. Fortunately, nowadays, there is no reported cases of tazocin or piperacillin tazobactam related false positive galactomannan. Other possibility is a post-transfusion cross-reaction with other form of mold like Fusarium, and the first 100 days for post-hematopoietic stem cell transplantation. So this is a message that you always correlate and integrate the finding in mycology markers or any infectious disease marker with the clinical setting rather than taking the readings or the results alone. So when we talk about respiratory specimen, when we talk about invasive pulmonary aspergillosis, it's very important to know what type of a specimen. So when we talk about sputum and tracheal aspirate, it's easy to obtain, but again, the sensitivity is only 30 to 50%, which increase the possibility of colonization. As Dr. Hail mentioned, the aspergillus is everywhere. So the possibility of colonization will be high if the sample is not deep in the lung. The specificity is only 50%. Now, combination of positive culture in these samples with positive fungal stain typical finding in microscopy might be suggestive of more true infection, especially in the setting of host and radiological findings suggesting the disease. Now, bronchoscopy with the bronchoalveolar lavage considered the best sample. It's also visualization for plaques or infection of the tracheobronchitis also. So it has better sensitivity and specificity when you compare it to that sputum or tracheal aspirate. And also you can utilize the molecular test and PCR, which was actually validated for the BAL to be used with sensitivity can reach 90%. So in the setting of negative PCR from the BAL and low pre-test probability, aspergillus diagnosis in the ICU will be very unlikely. So again, the problem with the bronchoscopy, especially when we talk in the last year or the last 2 years with COVID patient, we try to avoid unnecessarily aerosol generating a procedure at risk of nosocomial transmission with SARS-CoV-2. So again, this is one might have difficult to do bronch before for COVID patient to diagnose invasive aspergillosis, while the trach and sputum will be more simple but less sensitivity. So when we talk about the classical criteria in hematology malignancy, so still ICU patient, they could have a brand neutropenic patient sick, hematology malignancy, these criteria will be applied, the previous criteria that is related to the host, clinical, microbiological. So when we have only host risk factor, like a patient who did stem cell transplantation and a graft versus host disease with typical clinical presentation like hemoptysis, pleuritic pain, but without any mycological criteria in the setting of abnormal CT chest or typical CT chest finding of halocine, we call this possible invasive aspergillosis. Now in the setting of positive microbiology, and again, we mentioned the microbiological start from sputum and end by bronchoalveolar lavage. It's variable in sensitivity, and the presence of galactomannan antigen positive in the lavage with the clinical and host factor consider a probable invasive aspergillosis. So the only time that we call it a proven or definitive to have histopathology diagnosis. While when we talk about ICU patient who has, as we mentioned, non-classical risk factor and also non-classical CT finding, you need at least to have the, to elaborate each case by case carefully because of higher possibility of colonization in such patient in the ventilator. So we need here more than one risk factor, at least one clinical risk factor and one abnormal CT scan image criteria, and at least 2 mycological criteria to call it as probable invasive aspergillosis. If these are absent, this must likely considered to be colonization or maybe other diagnosis. So when we summarize it here in one slide, we can see that probable and possible aspergillosis is more applied to hematology malignancy patient, while putative, which is similar to probable in ICU patient, or colonization should be interpreted based on all of these criteria that we have mentioned, which most of it actually non-specific. So it should be always taken in consideration the possibility of colonization. So this is summary maybe of the whole presentation. When we talk about ICU patient, we can classify them based on a clinical, radiological, and mycology criteria, which should be taken in consideration the non-neutropenic ICU patient. So absolute diagnosis related to histology, high risk criteria is again immunocompromised and non-immunocompromised nowadays. Post-viral pneumonia, who have respiratory failure and difficult to wean from the ventilator. Strongly positive galactomannan from the bronchoalveolar lavage, more than one. And if there is any classical CT finding. Whereas moderate, when you have a sick patient who has other risk factor, who had positive galactomannan, but it's 0.5 to 1 and just abnormal CT scan. Now, low probability if you have only positive culture and abnormal X-ray, and it will be very unlikely if you have normal CT scan and negative mycology criteria to label the patient as Spirogyllus. This is just to show you that Spirogyllus is not the only mold. There is other molds. You need to keep it in mind, although it is rare, but it has been reported. So especially if you talk about the skin, eye manifestation, and positive blood culture, this is typically with the Fusarium. And it is similar actually with histopathological finding when we talk about Fusarium and Aspergillus, but again, about the spore or microconidia will be typical banana shape in microscopy examination for the Fusarium. And the last thing to remember that in India during the COVID pandemic, they have outbreaks of mucormycosis that is related probably to overuse of steroid. So maybe in the future, this type of mold, even considered rare, should be kept in mind, especially if you start the patient on voriconazole and has shown no improvement. Again, you should go back and discuss the result or take maybe histopathology to diagnose mucormycosis and discuss the result with the pathologist in your hospital because the mortality is very high. It's rare, but it's associated with a very high mortality. Thank you.
Thank you, Dr. Mohammed. I would like to invite all speakers to receive any question from the audience.
So we will open the floor for any questions. Please, if anyone has any questions, you can just Mustafa.
Well, thank you very much, and I know this is the end of the day, and thank you for these nice presentations, and thank you very much. I just have a question for Dr. Hail. The data that was presented about the Candida parapsilosis from King Faisal and Riyadh, where you have shown the susceptibility to fluconazole have declined significantly over time. Was this replicated elsewhere, or is specific to the institution? Because honestly, this is a bit alarming to us to see this parapsilosis going this direction. This is really going south. So if you can comment on this, Dr.
Yeah, unfortunately it is actually. There was a systematic review looking at all the studies of parapsilosis done over the years. They looked at from the mid-90s until 2016, and then after 2016. And actually it has risen up significantly. If I remember right, it was like 3.6% to like 17% resistance globally in these multiple studies. So yes, it's happening throughout, not only with us. And it is alarming. I mean, I always looked at parapsilosis as a benign candida, and nowadays no longer. Actually, we had a few that were resistant to all. The pollens, we don't have breakpoints, but it was one, the MICs for ampho, but the canocandids were resistant as well as the azoles. It was a parapsilosis.
Thank you for the very nice presentation, Doctor. I am Dr. Nazia from Infection Control in King Saud Medical City, Riyadh. Dr. Hayal again. Regarding the data for Candida auris that you showed us from the MOH with the number of outbreaks and the number of positive cultures that were identified, definitely we saw a very big line for Riyadh compared to other areas. Can we take into consideration the fact that the diagnostic modalities to identify Candida auris is more in Riyadh? That is why the line was very high compared to other areas, and maybe the prevalence in all other parts of Saudi Arabia is much more than what is seen there.
Thank you for this question. I think the diagnostic modality now is available because they do it through VITEC too, and it is available actually throughout labs in different places. This is why actually, if you see my graph, yes, Riyadh, but also other regions, now they've started actually screening policy. So they're screening for hours, so we expect with the screening, of course, to go up. Just one thing, I'll take this opportunity to talk about something probably I haven't had the time to go over it, which is, again, the shortage of nurses, especially in the ICU, I think has affected infection control big time. And I had discussions even at the administrative level with the leaders of nursing and how can we, care better in ICUs. And they said they're satisfied actually because they use this acuity type of ratio. So if you have a patient who's not as sick with another who's sick, maybe you can give it to one nurse. But this does not account for that who's not sick, colonized with auris, with a sick patient who's not, and eventually he come up with Candida auris in the blood with a mortality of, I haven't shown the mortality, but it's over 50% actually with auris. So that's alarming. So I think the modality is, of diagnosis is available to most laboratories because it's automated, and nowadays it's okay because the library was updated in these type of machines.
If I may just ask a question to Dr. Yamama, my colleague here. So, you have presented nicely that Candida score has a negative predictive value of more than 90%, I think, if I'm not mistaken. But looking back to the Candida score itself, we find that a lot of the classical risk factor for candidemia is not considered in the score, like being in central line, or the duration of the stay in the ICU, or the previous infection even with Candida being on broad-spectrum antibiotics. So can we, plus that did it consider a lot of baseline characteristics of the patient, being immunocompromised or not? So can we still depend on a Candida score in our preemptive treatment strategy in our hospital?
Thank you for your question. Now, one of the things that Candida index score, it incorporates the Candida colonization and the scoring system with the points for the risk factors in the patient. And this can give better predictive modality for those patients. But the problem with the ICU patient and the Candida infection, and one of the major challenges is that when it comes to candidemia or invasive candidiasis, you don't have other specific pictures related to candidiasis. It's not like invasive aspergillosis, you will look at the radiological, sometimes radiological manifestation. Here with the candidiasis, and especially if you look only on candidemia without deep-seated infection, there isn't other triggering. Most of the time, the empirical therapy or the trigger to start therapy is just based on those risk factors and sometimes the persistence of the fever. You don't have anything else in the clinical picture of the patient that can tell you whether or not he's.
Thank you. As you see, these scores, colonization and Ostrowski-Zieschner criteria, and the beta-glucan, they have a very good negative predictive value. But we could not utilize it. I mean, for whatever reasons, these meant nothing in terms of initiating antifungal therapy. So actually, nowadays, we are thinking of dropping the beta-glucan. We fought big time to have it in our hospital. Its utilization for years now, we haven't seen it, and it costs about 600 riyals per test, and just hasn't changed the practice. So again, if you have a tool but you don't use it, or then it's of beta-glucan, and all of the negative predictive value data has not really helped us in the ICU for various reasons. Some of them is still predictability, and some of them is the type of care within the ICU and the treating team.
Dr. Muhammad, regarding the invasive aspergillosis, should we still consider invasive aspergillosis an immune compromised patient in the ICU?
So the main problem with the ICU in diagnosing invasive aspergillosis that you difficult to get definitive. How many of the ICU patients you can do biopsy for them? This is one challenge. The other challenge, that the high possibility of colonization. The third challenge, that they already sick patient. So interpretation of the case should be very careful. And as I mentioned, they will have invasive tissue rather than angio-invasive, although even ICU patient, they could have, for example, a risk like hematology patient. They could be immunocompromised, taking this, especially post-COVID or post of, the patient who would receive, for example, a steroid in the ICU for other reason. So still, yes, it's considered invasive aspergillosis by definition. It's invasive. But again, the difficulty how to diagnose it or differentiate it from colonization while they don't have a classical risk factor or no classical CT finding. And maybe Dr. Hatta has a comment for aspergillosis.
Thank you. Yeah, aspergillosis is trouble. In the hematology oncology, febrile neutropenia, our life is a little easier from sort of indication for empiric therapy and suspicion of aspergillosis. On the other hand, it's difficult because we cannot do biopsy because of the thrombocytopenia, the coagulopathy, and sort of. On the contrary, in the others, influenza or COPD, it's the other way around. It's really hard to make a diagnosis. You see those infiltrates, you don't know. It's not as common as in those febrile neutropenics and bone marrow transplant. But probably in many patients you will be able to sample. Unfortunately, in the ICU on a high PEEP or on the ventilator, then doing an open lung or doing a needle is not feasible. But I see it more difficult than the hematology oncology in terms of taking decision towards starting antifungal therapy. Because again, antifungal therapy is not a simple decision. And you're committed to that without evidence. You don't know in a week, in a couple of weeks, what to do with your antifungals. So it's really troubling.
Any more questions? I think we can conclude now. I would like to thank the presenters and the speakers. Thank you very much for the nice session. Have we one question? There is one last question.
Dr. Fatin from King Fahd Military Medical Complex, infectious disease doctor. I want to ask about the combination of antifungals. Is there a place for combined therapy for Candida auris, like we say for Cryptococcus? There are some studies for that.
Yeah, I was not expecting it for auris. I was expecting it for aspergillus or other. Auris, we don't have data. Already we are compromised by the number of antifungals we have that are in vitro sensitive too. So I don't think we have data to indicate combo for auris. Of course, there's some not very good data on endocarditis for Candida giving combos. More pressure to use combos in aspergillosis because failures are more and it's difficult. And there has been several studies, initially more of a phase 2 or just a series, indicating maybe okay. Then we have the famous anidilafungin voriconazole versus voriconazole study, which showed a trend, p-value 0.09. But then when you use galactomannan alone as your diagnostic criteria for probable aspergillosis, then it goes to 0.4 or 0.5, 0.04. So if you believe your galactomanania has increased your sensitivity and probably there's aspergillosis, although as you've heard, we have false positives on that, then you can say maybe combo's okay. A lot of people, they go with combo as salvage therapy, and it's really unlikely to work as salvage. If you want to give it, probably you want to give it up front. And this study was not the most helpful. I personally use upfront combo in disseminated aspergillosis in bone marrow transplant and hematology oncology because the prognosis is dismal, and you want to give your drugs upfront. And this study indicates that maybe combo of anicanumab with an azole against aspergillus may be worthwhile.
So by this we reach the conclusion of our first day. Would like to thank Dr. Yamam Al-Jishi for her amazing presentation. Our panelist, Dr. Badr